Hello guys, yeah. I hope I'm audible and visible to you. Just give me a thumbs up if I'm audible and visible to you. Yep. Okay. I hope the voice is better than yesterday. I mean, day before yesterday. I'm really sorry I was not able to take the session yesterday due to some reason. Yep. So I'll just wait for a couple of minutes and then we'll start. For just 1 minute or so, we'll wait and then we'll start. Okay. Right, that's great. Now, if you wish to ask me anything, you can just put your comments in the chat box so that I can address that. I'm just waiting for literally 1 minute and then I'll be starting with today's session. We'll be conducting at least one or maybe two more sessions before your NEET PG kind of exam. And yeah. Okay, so we left at thyroid and now we'll be starting with the parathyroid. Okay. Okay, so I think we can start now. Okay, so what you need to understand is that, see, the primary and the secondary hyperparathyroidism and the tertiary hyperparathyroidism, yes, definitely that is kind of important. And I'm pretty sure you guys must have read that. So the primary is basically, parathyroid adenoma is the most common kind of cause for that. Okay. So I'll cover everything before 8 you're saying, right? Okay, so yeah, I'll do that. Probably tomorrow and day after tomorrow, I'll take the two sessions and I'll kind of wrap things up. Okay, so probably I'll do that. Okay, right? Okay, right. So let's start with the parathyroid without wasting any further time. Okay, right, sick. So let's kind of turn over beast mode on, and as the last session, I'll be slightly fast itself. I hope that particular speed was okay for you. Okay, yeah, obviously that would have been okay for you guys, and yeah, let's kind of start. So what we're going to talk about today over here is a Men's syndrome. Okay, so what is a Men's syndrome? I'm not covering the primary, secondary, and the tertiary hyperparathyroidism. You would have read that particular stuff in your what you call as medicine as well in a great detail. So kind of let's focus on that. Okay, now what about the Men's syndrome? What you need to understand is, so yeah, you can remember this particular mnemonic by Men 1 is consisting of 3 P's, then Men 2 is consisting of the kind of 2 P's, and Men 2B is Men 2A is basically consisting of 2 P's, and Men 2B is basically consisting of 1 P. What is this? So in the Men 1, what you need to understand is that there is involvement of a parathyroid, pituitary, and the pancreas. Yes, as rightly said, this is basically because of the mutation in the menin gene, which is basically located on which chromosome? Can you please tell me which chromosome is it located on? Okay, and what are the things which are involved over here? So as you can see over here, parathyroid. So here you have a parathyroid adenoma or carcinoma, that can develop, and then adenoma or hyperplasia, although not carcinoma per se, adenoma and the hyperplasia, those particular things can kind of develop. In the pituitary, what you have micro or the macroadenoma. So here again you have adenomas. And in the pancreas, what you have a neuroendocrine tumors. So which is the most common pancreatic neuroendocrine tumor which basically happens in the Men's syndrome? Okay, so which is the most common kind of neuroendocrine tumor which is associated with the Men's syndrome? The answer to that is basically the gastrinoma. Overall, the most common neuroendocrine tumor is basically your insulinoma, and absolutely right, this is basically the chromosome number 11. Okay, so this menin basically is located on the chromosome number 11, and the MEN2A and the MEN2B, both of these are basically associated with the red gene mutation, which are basically located on the chromosome number 10. Okay, so these are the ones which are basically located on the chromosome number 10. Now, what are the things which are there in the MEN2A syndrome? Parathyroid involvement. So again, parathyroid adenoma, hyperplasia can happen, and there is a pheochromocytoma. Along with that, what you basically get is a medullary carcinoma of thyroid, which you have already seen in the last section. Similarly, in the MEN2B syndrome, you have a medullary carcinoma of thyroid and you have a pheochromocytoma. And all of you are very well aware of this particular fact that in the clinical scenario, how do you distinguish between MEN2A and MEN2B? In the MEN2B, they are going to give you that there is what you call as a marfanoid habitus, marfanoid features, okay, or paragangliomas, okay, all those particular stuff they are going to give you if at all they wanted to mark it as a MEN2B syndrome. Now all of these, MEN1, MEN2A, MEN2B, what are these? All these are autosomal dominant. Okay, what are these? Autosomal dominant. Okay, so what are these? These are autosomal dominant, guys. Okay, so I hope you have understood this particular stuff, guys. Yep. Right. Okay, got it, got it. Mucosal neuromas and all those particular stuff. So yeah, we have covered all these particular things and kind of them. Okay, now let's move ahead. Now let's talk about the breast, guys. Okay, so now let's talk about the breast. Now in the breast, what you need to understand is whenever there is a patient who is basically going to come to you, and the patients you want to kind of examine these particular patients. So there are three things which you have. You have basically history, you have radiological investigations, you have histopathological investigation. History and the physical examination, I'll not go into the details. Radiological investigation. So I give you two questions. I want you to kind of give me the answer to that. So if I tell you that, you know what, there is a young female. Okay, so there is a young female who is basically what you call there's a young female who is basically having like if you want to screen a young female for what you call as just 1 minute, I'm looking for a blank slide over here. Just give me a minute. Okay, so I'll just kind of elaborate. You can answer it in the comment box. So what you need to understand, if at all they say that there is a patient who is there's a young female who in whom you want to kind of screen the patients. Okay, so you want to kind of screen the patients, a young female patient in the general population. What is the radiological investigation of choice? So what I'm trying to ask you is that radiological investigation of choice to screen screen young female in the general population. What is the answer to this particular stuff? I hope that you are answering it as an ultrasound, guys. Okay, ultrasound. Why? Because mammography will not be kind of helpful, because in the what you call as a young females, the breast is relatively denser, and mammography will have a lot of artifacts and everything. But if at all they just tweak this particular question, if at all they say that, you know what, there is a female, let's say the female is, let's say 21, 22 years, and then she gives you the history that the mother died of the breast cancer. So mother basically died of breast cancer. Now you want to screen this particular patient. So what is the thing which you're going to use? So for the screening of this particular patient, what you're going to use is an MRI. Okay, so I hope you're able to understand this. No, not just the BRCA gene. So radiological investigation of choice, I am asking for the kind of screening. So that is what is going to be your MRI. Okay, so yes, I understand your point. You will order that, you know what, just get an BRCA gene kind of done. But what you need to understand, radiological test which you're going to offer for the screening of these particular patients is an MRI. Okay, now what is this? This is what is a mammogram. That's fine. What is the radiation exposure? 0.1 to 0.2 centigrade, that's fine. Now what you have on your screen is basically called as a BI-RADS. So what on earth is this particular BI-RADS, guys? What is this particular BI-RADS? So what you need to understand is that BI-RADS basically stand for breast imaging reporting and the data system. Okay, what does it basically stand for? It basically stands for breast imaging reporting and the data system. Now why on earth this particular BI-RADS was kind of brought into existence? Okay, so this basically helps you in simplifying the communication between the kind of a radiologist and the clinicians and everything. For example, if at all there is a female who is coming to you with a BI-RADS of let's say 3, everybody will understand what that particular radiologist wanted to kind of talk to you about. Okay, are you understanding my point? So this is basically done in order to standardize the radiological investigations across the world. Similarly, now we have PI-RADS, prostate imaging reporting and data system. Then we have VI-RADS, that is vesicle imaging reporting and data system. So VI-RADS, okay, VI. Okay, now off topic, not related to this, but if at all they ask you VI-RADS, this is for which particular kind of organ? VI-RADS is basically for vesicle, that is urinary bladder. Okay, so this is for bladder cancers. VI-RADS, they are basically trying to kind of develop for urinary bladder. I hope you are able to understand this particular point, guys. Okay, right, now coming to the BI-RADS, then BI-RADS, what you have 0, 1, 2, 3, 4, 5, 6. Okay, so what you essentially what you really need to understand is this. Okay, probably benign, BI-RADS 3. So if at all there is a female which basically comes and the patient basically is having the report of probably benign, it means that yeah, most likely it is a benign lesion, but there is a small risk of malignancy is there. So will you advise a biopsy? If you logically think in your examination hall, if you are forgetting this particular table, and if at all the question says that in the BI-RADS 3 kind of female, what are you going to do? Obviously, if you know the answer, you know the answer. But if you don't know the answer, you will remember that, okay, it's a probably benign. Okay, maybe there is a slight risk of malignancy. Let's get a biopsy test. No. Here, what you basically do is, you reduce the duration of the screening. You reduce the duration of the screening from 1 year to 6 months. Okay, but from BI-RADS, whatever 4 and 5 and everything, here you can basically get a biopsy done, because now it is a suspicious and highly suspicious of malignancy. So please try to understand, probably benign, you don't get a biopsy done. What you basically do is you reduce the duration of the screening. And then what is the BI-RADS 6? BI-RADS 6 is basically biopsy proven malignancy. It means that the patient is already having a true cut biopsy, which basically shows that the patient is basically having a malignancy. Okay, Okay, now what you need to understand over here, what you are basically seeing in front of me, like behind me, is MRI of the breast. What are you basically seeing is the breast implant. Okay, now what is this? Anybody can tell, let me know this sign of this. I'm pretty sure you guys must be knowing it. What is this? This is what is a linguine sign. Okay, what is this? This is what is a linguine sign. What is this? This is basically a sign which you basically guessed in the ruptured breast implant. Okay, so ruptured breast implant, what you basically get is a linguine sign. Now they keep on asking you, right, what is the indication of doing an MRI? So straightforward, you should remember these particular 6 investigations, very, very important. Breast implant. Okay, so if at all there is a patient with a breast implant and you want to evaluate that particular patient, definitely you'll have to get a MRI done. Then in order to look for multifocality and the multicentricity, why this is important? Whenever we are talking about, let's say, a breast conservative surgery, we want to do a surgery like if at all it's a unifocal, if at all let's say it's limited to one particular quadrant, then only we are able to perform a breast conservative surgery. And in that particular scenario, it is very, 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 very important is this. Okay, I hope you are able to understand this point. Now scar recurrence, yeah, if at all let's say the modified radical mastectomy has been done and now you want to see whether the recurrence is taking place in that particular area or not, mammography is not going to help you, so you have to kind of get an MRI done. Screening for the familial cases, we just talked about ductal carcinoma in situ. Okay, so please try to understand over here, ductal carcinoma in situ, what do you basically get? You basically get microcalcifications. Okay, what do you get? You get microcalcification. So does MRI pick up a calcification? Okay, so with this particular logic, don't get confused. Okay, so yes, we do get a microcalcifications in the ductal carcinoma in situ, but it is not just the only thing which you basically get. So there are other architectural changes as well, which are very well picked up by an MRI. So yes, in the ductal carcinoma in situ, we do kind of do an MRI. Then we have a ductal papilloma, not a mandatory investigations. Yes. Hence malignant. Okay, so you understand my point. So what you call as a ductal papilloma, then you basically have that. No, so try to understand in the mammography. So this is something which you need to understand over here, that in the mammography, what basically prompts you that, you know what, this is a malignant lesion, this is benign lesion. So if at all let's say you have a popcorn calcification, if you have a macro calcification, it is more likely to be malignant. If at all let's say there is a patient with a speckled calcification, or let's say there is a distortion of the architecture, all those particular things are there, then they basically prompt towards malignancy. Now what Satyajit is asking is that micro hence malignant, sir? No, not really. First of all, ductal carcinoma in situ, is it a malignant lesion? No, not really. It's a pre-malignant condition. In the ductal carcinoma in situ, how much is the risk of malignancy? These guys have 10-fold risk of malignancy. Okay, how many fold? 10-fold increased risk of malignancy. So if at all you have a ductal carcinoma in situ, then you do a simple mastectomy. You do not do a modified radical mastectomy. You can also perform a breast conservative surgery, that's fine. But yeah, the lymph node dissection you cannot do. Okay, so I hope you have understood this particular point. Ductal carcinoma in situ is a separate topic altogether, but I hope you have understood this particular point. So your thought process is kind of fine, because microcalcification, it is more likely to be malignant, but I hope you have understood this point. Ductal carcinoma in situ is not a malignant, it is a carcinoma in situ. It is a pre-malignant condition. There is a 10-fold increased risk of malignancy in these particular patients. Okay, now in the pathology, what you can do is you can do an FNAC, you can do a true cut biopsy, you can do an excision biopsy. What is a better one? Excision biopsy is a better. In the FNAC, what is the drawback? What is the drawback in the FNAC? The drawback which you basically have in the FNAC is that ER-PR receptor status is not known. ER-PR receptor status, it is kind of not known. Okay, obviously that's why what you basically need is a true cut biopsy and the kind of an excision biopsy. So true cut biopsy is kind of good, but if at all, okay, so after how many true cut biopsies you will perform an excision biopsy? If at all the true cut biopsy 2 fails. Okay, so if at all there's a patient with a suspicious lesion, you performed a true cut biopsy, inconclusive, you again perform a true cut biopsy, again inconclusive, now you will go ahead and do an excision biopsy. So the gold standard is this kind of excision biopsy, but the investigation of choice is true cut biopsy. This is what is a true cut biopsy gun, with the help of which you basically perform the true cut biopsy. Now they ask you which is the most common quadrant where the malignancy is going to occur. So upper outer quadrant is the most common quadrant of the breast where the breast malignancies usually occur. Okay, then the genetic mutations, we have a P53, BRCA1, BRCA2. So BRCA1 is located on the chromosome number 17, BRCA2 is basically located on the chromosome number 13. Do not forget this, this is very, very important. Okay, right now, what you need to understand over here, which is more aggressive, so BRCA1 is the one which is basically more aggressive. If you talk about what you call as like a breast cancer or an ovarian cancer and everything, what you need to understand, BRCA1 is the one which is more aggressive. They are the ones which are associated with the triple negativity. They are the ones which are occurring in the younger age group, and This is what is if at all there's a BRCA gene mutation, what you basically get is a breast cancer as well as an ovarian cancer. It is not just a breast cancer. I'm pretty sure that you guys know that. But when you talk about the other cancers, for example, let's say the pancreas or the prostate or the male breast cancer, in all these particular places, BRCA2 is the one which is more kind of aggressive. Okay, so I hope you have understood this particular point. If at all somebody asks you, the risk of the male breast cancer is associated with what? BRCA1 or the BRCA2? So it is associated with both, but the male breast cancer risk is more with the BRCA2 gene mutation as compared to that of the BRCA1 gene mutation. Okay, right? Okay, right? I hope you have understood this point. Okay, now this is all about the BRCA1, BRCA2. Okay, so if at all there's a patient who walks to you with a BRCA gene mutation, you can advise the patients what you call as a conservative management, and you can surveillance, and you will ask the patients to kind of work on the modifiable risk factors and everything. But the logical way to kind of go ahead is prophylactic bilateral mastectomy. Along with that, the patients are also have to remove the ovaries, so bilateral salpingo-oophorectomy. Along with that, you have to give these particular patients the hormonal therapy, chemoprophylaxis in the form of a tamoxifen. So all these particular things you have to kind of understand. Okay, so triple negative, yeah, triple negative ER, PR, and the HER2 new negative, that is what is in the BRCA. Okay, got it? Okay, right. Now what you need to understand is the TNM staging. Now this is absolutely important. Okay, so just kind of listen to me. I'm pretty sure you have gone through this a number of times. Just kind of revise with me once more. So what is the T1? T1 is basically less than 2 centimeters. What is the T2? T2 is 2 to 5 centimeters. T3 is more than 5 centimeters. So that's kind of done. Now in the T4, what you need to understand is that there is a T4A, T4B, T4C, and the T4D. Now the biggest kind of a thing which you need to understand over here is that sometimes I'm pretty sure you are not that particular person, but yeah, sometimes the students get confused that whether the T4A is involvement of the skin or the involvement of the chest wall. So whenever we screw up in our life, always we have to self-introspect first. So please try to understand T4A is basically involvement of the chest wall. And in the involvement of the chest wall, what all things are included? So involvement of the serratus anterior muscle, involvement of the ribs, and involvement of the intercostal muscles. All these things are basically included in the what you call as a T4A category. What is not included? Involvement of the pectoralis major and the pectoralis minor. That is not a part of your T4A. What about the T4B? In the T4B, there is involvement of the skin. Okay, so T4A is chest wall, T4B is involvement of the skin. So in the skin, if at all they give you that there is a podiorange or there is an ulceration or there is what you call as a nodule, then yes, you will say that you have a T4B lesion. But if at all they give you puckering of the kind of a skin or the dimpling or the nipple retraction, then that is not the skin involvement. Why is that occurring? That is occurring because of the involvement of the ligament of Cooper. Okay, ligament of the Cooper. Then we have a T4C where the involvement of a skin as well as the chest wall. Then we have a T4D where there's an inflammatory breast cancer. So done. So this is about the T stage. I'm pretty sure you know this and just kind of quickly revising it with you guys. What about the end stage? In the end stage, you have a N1, then you have a N2A, N2B, and then you have a N3A and A, B, and C. So what is N1? N1 is basically ipsilateral axillary mobile lymph nodes. Okay, what about the N2A? N2A is basically fixed or the matted. So what does this particular fixed or the matted indicate? Fixed or the matted basically indicates that, you know what, that there is an extranodal extension. So fixed or the matted basically indicate that there is an extranodal extension which is kind of present. What about the N2B? N2B is basically internal mammary lymph node, okay, with the absence of the axillary lymph node. So N2B is internal mammary with the absence of the axillary lymph node. Then we have a N3A. So N3A, what you have? N3A, B, and C. What is N3A? A is infraclavicular. B is basically involvement of the axillary plus the internal mammary lymph nodes. What is N3C? It is supraclavicular lymph node involvement. Okay, so I hope you have understood this point. N1, N2A, N2B, and N3A, B, and C. Okay, right? I hope you are able to understand this particular point. Okay, skin cancer in the cuirass. False. Cuirass. What do you understand by the cuirass? Okay, cuirass. So Teja, please kind of take this particular question in the group as well. I'll just ask you that. I'll answer this. What exactly do you mean by cuirass? Was this a question which was there? So if at all that was a question, just put it in the kind of a group, or otherwise I'll get back to you. Okay, cuirass. I did not get you. What you're basically trying to say. Okay, so inflammatory breast cancer, skin, or the interstitial or the parenchymal inflammation, blah blah blah. So please try to understand, inflammatory breast cancer is just a name which is given to you. It is not an inflammation or anything like that. So what happens is that it masquerades as the what you call as a breast abscess sometimes. Okay, so that is the basic thing that is why it is basically called as an inflammatory breast cancer, because externally when you look at that particular skin, there is a lot of inflammation and the skin erythema and all those particular stuff. So I hope you have understood this particular point. But underlying that, there is a malignancy which is present. So that is what is an inflammatory breast cancer. Okay, I hope you have understood this particular one. So skin and the subcutaneous tissue both are involved in that particular inflammation, if that's what you're trying to ask. So what is this? This is basically an image which is showing your body orange appearance. That is a what you call as a orange peel appearance, and all those particular stuff is fine. Now in the management of the breast cancer, what you basically have is you have the surgery, you have basically the chemotherapy, radiotherapy, and the what you call as the hormonal therapy. Okay, so all these particular things are there. What is this particular surgery done? This is basically a radical kind of a mastectomy. Nobody's going to ask you that, that's fine. But here what you're able to see is that the ribs have also are also visible. So basically what this means that the pectoralis major and the minor is also kind of removed. Okay, they are also kind of removed. Okay, I will get back to you, Satya. Like, I'm really sorry for this, but I'm not able to kind of resonate what you are basically trying to say. Maybe I'll just get back to you on this on the group for sure. Okay, so like I'm pretty sure that this would have been like some of the other question which you were trying to ask. I'll get back to you. So what Satya asked was that so skin cancer in the curus falls under which stage? She's saying the most. Okay, so I'll get back to you on that. Okay, so yeah, okay, got it. Now, so as I told you that this is what is a radical mastectomy, what you're basically seeing over here. So there's like a ribs visible, so pectoralis major, minor, everything has been kind of removed. I've taken this particular image from the internet, guys. Okay, so what you need to understand, this was a case which was kind of published at one place where they basically said that, you know what, they basically were trying to talk about the advances of the medical sciences and everything. So in the same person, what happened was that at one point of the time there was a radical mastectomy which was done, but later on, as the kind of days progressed, what happened, she might have developed the cancer on the opposite breast as well. And as you can see over here, this is what is a incision of a breast conservative surgery. So all they were trying to show is that in the same person, she has kind of lived like to a lifespan where like the two extremes of the surgeries were performed on the same surgeon, like same person. That's fine. Now let's talk about the modified radical mastectomy, because that is something which is kind of going to be asked to you. Okay, so what you need to understand here, what you remove, you basically remove the whatever the breast tissue obviously is going to remove. You're going to remove the lymph node stations 1 and 2. Usually you remove the 1 and 2. So what are these particular 1 and 2? They are divided based on the pectoralis minor. So lymph nodes which are basically lying lateral to the pectoralis minor, the lymph node station 1, below the pectoralis minor, that is your rotors kind of lymph nodes. Oh my god. Okay, so below the pectoralis minor, that is basically your what you refer to as your lymph node station 2 and all those particular things. Now what you're doing with the pectoralis minor, based on that you basically divide them into the 3 categories. What you have is a Auchincloss, you have a scanlon, and you have a Pettis. In the Pettis, what you basically do is you remove the pectoralis minor. In the scanlon, what you do is you cut the pectoralis minor, and then once you have removed that particular node, you basically rejoin that particular muscle again. And in the Auchincloss, what you basically do is you retract the pectoralis minor and then you remove that particular node. So which is the most commonly kind of performed procedure in the modified radical mastectomy? It is an Auchincloss. So Auchincloss is the one which you basically perform most commonly in the clinical practice. Now there are the boundaries of your what you call as the axillary dissection in order for that particular lymph nodes and everything. So what you need to understand, the superior boundary is basically the axillary vein. Okay, so what is the superior boundary? It is basically the axillary vein which you have. Now then what we have is the lateral boundary is basically your thoracodorsal pedicle. The medial boundary is basically Halstead's ligament or the costoclavicular ligament. And then finally what you have is your inferior, like it's not visible on your screen, but it is basically an angular vein. So these are the boundaries of what you call as your axillary lymph node dissection. So just remember these particular boundaries. Sometimes they kind of tend to ask you these particular stuff, but Auchincloss is the modified radical mastectomy which you most commonly perform in today's time. So that is what you need to understand. Now what is this breast conservative surgery? In the breast conservative surgery, what you basically do is you remove the one particular quadrant of the breast. So if at all, let's say there is one particular lesion, you are going to perform a wide local excision of that, and then what you're going to do, you are going to give a radiotherapy to that particular area. Why you want to give a radiotherapy? Because you want to prevent the recurrence. Okay, now just imagine that if at all there is a person, let's say assume that I am a female and I am basically having a breast cancer, and I have basically the 2 options in front of me, let's say modified radical mastectomy or a breast conservative surgery. So what you need to understand is that if at all that particular patient chooses a modified radical mastectomy, the outcome of that as compared to the breast conservative surgery with respect to the mortality. So mortality is going to be the same whether the patient chooses the modified radical mastectomy or the breast conservative surgery. I hope you're able to understand this point. But if you compare them head to head with the recurrence is definitely going to be more with the breast conservative surgery as compared to that of your what you call as the modified breast conservative surgery as compared to that of the kind of a modified radical mastectomy. Okay, I hope you have understood this particular point. Now what you need to understand over here is the margin. What is the margin of resection which you're going to take? So in the in the wide local excision, you take 1 centimeter margin. Now sometimes the students ask that, so can we take, let's say, 1 millimeter of the margin? So don't get confused. In your Love and Bailey, what they have written is that there are few studies which are being performed where they are trying with the 1 millimeter of the margin. But till date, what is kind of standardized is 1 centimeter of the margin. So what you have to take is basically 1 centimeter of the margin. Maybe let's say 5 years, 10 years down the line, we will kind of reach to a place where we will be able to kind of take a lesser margin, because at the end of the day, we are trying to conserve the breast. Okay. Now, what are the absolute contraindications for this particular breast conservation surgery? So pregnancy. Okay, so if at all the patient is pregnant, obviously we will not be able to give the radiotherapy to that particular patient. And then if at all you have a multifocal or the multicentric kind of lesion, then again that particular what you call as a wide local excision cannot be performed. Rest all, let's say socioeconomic status or the size of the tumor as compared to the rest of the breast and everything, all these particular things are the relative contraindications. Okay, so I hope you have understood this point. Absolute contraindication is the pregnancy and that. Okay, so this is about that particular stuff. Okay, now before proceeding ahead, okay, so axillary dissection means, okay, axillary dissection means so you have to remove this particular lymph node, right? Lymph nodes are basically present in the axilla, what we talked about as the N1, N2. So axillary lymph nodes. Okay, so we have to kind of remove these particular lymph nodes. Okay, you understand my point? Because we want to see whether there is any metastasis in these particular lymph nodes or not. So whenever we perform a modified radical mastectomy, we also remove the lymph node positions 1 and 2. 1 is basically those lymph nodes which are lateral to the pectoralis minor. 2 basically means those which are basically behind this particular pectoralis minor. Okay, then we have all these particular complications which can happen. Obviously hemorrhage can happen, no doubt. Injury to the nerves can happen, so thickening of the scapula, all those particular things can happen. Which is the most common nerve injured? So intercostobrachial nerve. Okay, so what is the most common nerve injured during the surgery? Intercostobrachial nerve. That is basically the sensory supply to the medial aspect of the arm over here. So that is what is the most common nerve which is injured. Then what is the most common complication is the seroma, and that is the reason why you basically keep this. What is this? This is what is the Romo-Vac drain. Okay, so Romo-Vac drain, this basically creates a suction, so that whatever the seroma is going to be formed, it basically sucks that particular thing out. Okay, now if at all this particular drain is blocked or this drain is accidentally removed or something like that, what can happen? The seroma can get accumulated over there. If at all the seroma gets accumulated, you can just simply put remove a couple of sutures and you can drain the seroma, and then you can put a compression dressing over it. But if at all that seroma has got infected, now you cannot just remove the 2 sutures. Now you have to kind of remove all the sutures. You have to make it kind of an open wound, and now you have to kind of do the dressing every 12 early. I hope you have understood. A couple of years back, this particular concept was tested on you on your exam day, so please try to understand this particular point. Now, flap necrosis, if you whatever the flaps of the skin are very, very thin, then the flap necrosis can occur. Now the lymphedema. What about this particular lymphedema? So what you need to understand is that if at all, let's say you have done an aggressive lymph nodal dissection, or let's say the radiotherapy has been given to this particular part or something like that, the lymphedema can occur on the upper limb. So what is this particular lymphedema? That is, the upper limb is basically swollen, right? Are you understanding? So lymph is basically, there is going to be the problem with the drainage of the lymph from the upper limb into that particular thoracic duct and everything. And that is why what you need to understand over here is that there's going to be a problem and the lymph will get accumulated over here. So this is what is referred to as a lymphedema. Okay, so just the presence of the swelling in the upper limbs is called as a lymphedema. Now, if at all that particular swelling is kind of present for a prolonged period of time, let's assume 8 years, 10 years or something like that, and in the question they are going to distinctly give you that there is a development of a hemorrhagic nodules. Where did it go? Okay, so if at all there is a, okay, so if at all they say that there is a development of a hemorrhagic nodule, okay, hemorrhagic nodule or ulceration in that particular lymphedema, which is going to take place, let's say, after 8-10 years or so. This is what is a transformation of a lymphedema into the lymphangiosarcoma, and this is what is referred to as your Stewart-Travis syndrome. What is this called as? This is what is called as a Stewart-Travis syndrome. So very, very important. I hope you have understood this particular point. Okay, got it? Okay, now please try to understand that by it is not a flap which I'm trying to talk to you about. This particular flap is, you basically give an elliptical incision over here and you raise the skin flap. And that get kind of necrosed. Okay, so what you are trying to refer to as most common flap used, that is basically for the reconstruction. So yes, in that what you basically use is a DIEP, which is basically a free flap, which is basically based on the deep inferior epigastric pedicle. So this is basically used for the breast reconstruction. So I think you were trying to to ask that only. Okay, so earlier what we used to use whatever the serratus anterior and like latissimus dorsi and everything, but that was kind of not done. Then we started using the transversus rectus abdominis muscle, tram flap. Okay, now tram flap can be of two types. It can be either a pedicled, or it can be what you call as it can be a pedicle tram flap, or it can be basically a free flap. Okay, so what is a pedicle tram flap? Let's assume that this is what is a transversus rectus abdominis muscle. So this is over here. So what you can do is you can cut the blood supply of the lower end, and now what you can do, this is basically a flap which is based on the pedicle. Now you can basically turn the skin and you can bring it over here, and then you can kind of whatever to do the reconstruction. So this is what is called as a pedicled tram flap. Now this is something which is not used. Now what you basically use, which is can be used, that's fine, but which is the more preferred flap is the DIAP, which is deep inferior epigastric flap. Now this is again a transversus rectus abdominis muscle. You can cut the muscle which is below, and then you can take a part of that particular muscle, and then you take the subcutaneous fat also along with it, and then you kind of bring it, you kind of detach it, and then you again kind of bring it, and then you anastomose it to the vessel over here, and then you do the reconstruction. So the advantage of this is that it's going to have a fatty component as well. So abdominal fat is basically coming along with it. So the advantage is that it is going to give a more natural appearance to the breast. Okay, so I hope you have understood this particular point. So yes, you are absolutely right, which is the more commonly used flap for the breast reconstruction is a DIEP flap. That is what is the most preferred flap in today's time. Okay. Now, this is what is the molecular classification. I'm pretty sure that you guys know this. So what is more common? So invasive ductal carcinoma is kind of more common. Now this is important for you guys. Luminal A, luminal B, BCL, and the HER2/neu. I'm pretty sure you would have covered this in your pathology as well. But yeah, what is a luminal A? The luminal A, what you basically have is ER/PR is positive and the HER2/neu is kind of negative. In the luminal B, what you have, ER/PR is positive and the HER2/neu is also positive. In the BCL type, what you have is ER/PR is negative, HER2/neu is also negative, and in the HER2/neu positive, as you can see, only the HER2/neu is kind of positive, right? So luminal A is the one which is basically having a good prognosis. Okay, so best prognosis rather is kind of present with that. Okay, right. Okay, understood. Now let's talk about the hormonal therapy. So in the hormonal therapy, what you need to understand is that first the prerequisite for giving the hormonal therapy is that ER/PR receptor should be kind of present. Now you basically have it for what you call as a premenopausal and the postmenopausal woman. In the premenopausal woman, what you need to understand is what you give is a SERM. What is the SERM? Selective estrogen receptor modulator. So what is this selective estrogen receptor modulator? It is going to have a positive effects on few receptors of the estrogen, and it's going to have a negative effect on the few places. So in the breast, it is going to have a positive effect. It is going to prevent the breast cancer, but in the legs, it is going to kind of increase the risk of the deep venous thrombosis. In the endometrium, it is going to cause an endometrial hyperplasia, and it is also going to kind of lead to your hot flushes and everything. So that is what is a problem with this SERM, like selective estrogen receptor modulator. In the postmenopausal woman, what is the source of the kind of estrogen? Can you please help me with this? Okay, so the ovaries are not functioning at this point of time. So let's kind of get over here. So what happens is that the testosterone is getting converted to the estrogen. So where on earth the testosterone came in the old woman, right? So what you need to understand is that the adrenals produce the testosterone. Now this particular testosterone will get converted into the estrogen by the aromatase. Aromatase is an enzyme which is basically present in the fat, and that is what is going to convert this adrenal testosterone into the what you call as an estrogen, and that is what is going to kind of help this. Okay, so here what you basically do is there is an aromatase inhibitor. So anastrozole, letrozole, all these particular things are the aromatase inhibitor, and they can be used in the postmenopausal woman. Okay, so this is how you basically perform in hormonal therapy in these particular patients. Okay, now can you please tell me what is the management of this particular thing? I hope, yeah, it's very well visible over here. So can you please tell me what is the management of this particular cyst? Yeah. Simple question, guys. Okay, so if you're saying that you know what, aspirate this, no, this is what you're dealing with is a complex cyst. Okay, so what are you basically seeing over here? I hope you're able to appreciate that this is like a solid component inside this particular cyst. Okay, so what is this? This is what is a complex cyst. So whenever you have a, okay, now I'll just show you the simple cyst as well. So this is what is a cyst. Okay, now is it a cyst or something else? I argue, okay, I say that no, this is a stone inside the breast. So can you prove me wrong? Yes, you can prove me wrong. Why? This is a very, very simple concept, but yeah, I hope you remember this. Okay, so what you need to understand over here, what is this? What I have kind of shown over here, this is what is a posterior acoustic enhancement. Okay, what is this? posterior acoustic enhancement. Okay, are you able to understand this particular point? So what you're basically seeing is with an ultrasound, so there is an anechoic lesion, which is basically the cyst, and behind this particular cyst, what you have is an hyper intense kind of a thing. Okay, so what is this? This is what is a posterior acoustic enhancement. In the stone, what you're going to get? You're going to get a posterior acoustic shadowing. Nothing related to the breast. Very, very simple concept of radiology, tested sometimes. In the stone, what you basically get is a posterior acoustic shadowing. In the cyst, what you basically get is a posterior acoustic enhancement. Okay, now what is this? This is basically a simple cyst of the breast, and here what you're basically going to do is you're going to aspirate it. Okay, you're going to aspirate it. But okay, so what you need to understand, whenever you have a breast that you aspirate, if at all the whatever the contents are clear, no blood stain, nothing, okay, and if at all that particular lesion completely kind of subsides after you have kind of aspirated, do nothing, you can just observe that. But on the other hand, over here, what you're going to do, if at all you're going to aspirate it, the cyst is not going to kind of completely disappear, because there is a complex cyst, it has some solid component as well, so it is not going to kind of completely disappear. There's going to be some kind of residual kind of effect, residual lesion is going to be there, and if at all, let's say you aspirate and there is a blood stain, then in that particular scenario you'll have to excise it. So it is never an IND, guys. Okay, it's never an IND. What you basically have to do over here is aspiration. If at all it is a blood stain, or let's say if at all there is a residual lesion, then you have to excise that particular cyst. Okay, so this is what is in so this, you can just go through this. This is what I just explained it to you. Okay, now what is this? This is again a very, very simple image which you need to understand is what is this? This is what is a popcorn calcification. What is this? This is basically a what do you call it, a fibroadenoma. Okay, so definitely it's a benign kind of a thing, and it is called a breast mass. Obviously all those particular things, you know that. On the diagnosis, mammography, it's kind of done. What you basically get is a popcorn calcification. Okay, popcorn calcification. Now for the like excision of this particular fibroadenoma, there are various kind of schools of thought. So what you need to understand is that if at all you're dealing with a younger female, let's say 20, 22, 23 or something like that, never kind of go ahead and do this particular excision of the fibroadenoma, because it is a benign kind of thing. Why do you want to kind of do that? Unless you suspect a malignancy, or let's say you suspect some atypical fibroadenoma, it's a painful or something like that. Why? Because no matter how good you kind of operate, what is going to happen, few or the other breast ducts are going to get damaged, and over a period of time they can become stricturous, and when the patients basically breastfeed, at that point of time the patients are going to have a bit of a problem. Okay, so that's what you need to understand. In the younger patients, you do not prefer to kind of operate unless it is, let's say, suspicious, or let's say there is a lot of pain which is associated with it. Okay, so just a small bit, nothing major about this. Okay, now what is this, guys? What is this? So this is what is a breast abscess. Okay, so this is a breast abscess. Okay, so what is the most common cause of the breast abscess? Small children. Okay, when they basically feed on the kind of a like the babies, when they kind of feed on the breasts of the females and everything, what you need to understand is that if at all the nipples develop cracks or something like that, the infection or the bacteria can basically ascend through these particular cracks and can go to the breast and can lead to the infection. So what is the most common organism? Yes, absolutely right. Staphylococcus aureus. Now what you need to appreciate is, now it might seem very, very simple, but you need to understand how do you distinguish between a breast abscess and a mastitis. So if at all they say things like fluctuant swelling, or if at all they say that there is a high grade fever or something like that, it as a breast abscess. But if at all they say there is an erythema, there is a pain, all those particular things, then it probably can be mastitis. So depending on the framing of the question, you'll have to kind of understand what are they basically talking about. Yeah, guys, am I audible and visible? I think the internet got a bit slow in between. Yep, I hope I'm back. Yep, I hope I'm back. Okay, right. So yeah, that's what you need to understand. Now the most important thing is the management. Okay, so how are you going to manage these particular patients? Okay, so if at all there is a patient with what you call as let's say breast abscess, what is the management of the patients with the breast abscess? Can you please help me with this? So please do not mark it as an IND. Okay, IND is not done. So why you don't do an IND in these particular patients? Okay, why you don't do an IND in these particular patients? So please try to understand this. Oh no, Satyaja, no, never an IND is done. Okay, why you don't do an IND? Very, very important. Okay, this concept, if you have to kind of understand this particular concept, you don't do IND in these particular patients. Why you don't do IND? Because these particular females are basically lactating, right? So what you need to understand, like no matter how good a surgeon you are, invariably you're going to kind of cut through these particular few of the ducts. Doesn't matter whether you give a radial incision, whether you give a circumventral. Obviously, like you would have read all these, right? The radial incision and everything, that's all fine. But no matter how fine a surgery you basically do, you will end up kind of injuring some or the other kind of lactiferous duct. And if if at all you kind of do that, what's going to happen? The milk will continuously kind of flow from that particular duct. This had happened when I was a resident. There was one patient in the OBGYN. We ended up doing an IND at that point of time, and then all those particular things were kind of doing that. Okay, so I hope you are able to understand this point. So you love and Billy emphasizes so much on this particular point, and you should kind of remember this. If at all there is a abscess, you ultrasound guided aspiration. That is what you do. If at all there is a recurrence, you again reaspirate. If at all there is a recurrence, again you reaspirate. No doubt, you're going to give an antibiotics, no doubt. If there are multiple abscesses, you do an ultrasound guided aspiration, and that is also what you basically do in today's time in the clinical practice as well. Okay, so please try to understand this particular point. Very, 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 very important. And you have also been tested on this a couple of times. Okay, so please do not mark an IND. If at all there is a breast abscess, you have to go ahead with an ultrasound guided aspiration. Okay, I hope all of you have understood this particular point, guys. Okay, now there are two conditions. One is basically called as a ductal papilloma and the ductal ectasia. Let's not go into the details of it. At least remember the management of these. Okay, so in the ductal papilloma, what you basically do is a microdocectomy. In the ductal ectasia, what you basically do is what you call as a Hatfield procedure. Okay, so in the ductal ectasia, what you basically do is a Hatfield procedure. In the ductal papilloma, what you do is a microdocectomy. So please do remember these particular names. Hatfield procedure has been asked to you once. Okay, so I'll just take one question. So, sir, IND can lead to Mondor's disease too. No, so Mondor's disease is absolutely different. Okay, so Mondor's disease is basically that there is a what you call as the inflamed and the thrombosed superficial vessel. That's absolutely different. That has nothing to do with an IND. So what you need to understand, why you do not do an IND in these particular patients, because these are the lactating females, and if at all you injure the ducts, what's going to happen? Continuously the milk is going to kind of continue to flow from that. I'll just share a real experience. Okay, so I told you about that particular female, right? I was the first year resident. We did an IND like our HOD and all those particular things. They asked us, and that's fine. We did an IND. So what happened was that she was basically completely kind of draining the milk continuously from there. So we used to do the dressing 2, 3, 4 times in a kind of day or something like that. But what used to happen, the entire dressing used to get soaked with that particular blood only, like with that particular milk only. Are you understanding my point? So very, very important. What you need to understand is that IND. So your Lavin Bailey doesn't even mention IND as one of the options in the breast abscess. So that is what you need to understand over here. Okay, understood? Well, yes, ductal ectasia, greenish discharge, that's fine. But what else? What else? So sometimes they can also give you serous discharge. Okay, so yes, ductal ectasia, I hope you have understood this. Okay, got it, right. Now, Rishabh, what you need to understand is, yes, no doubt, in the ductal ectasia, what you're going to get is a greenish discharge, no doubt about it. But at the same time, there is also something which is called as a serous discharge. Now this is a bit less talked about, but this is also very, very important. So not like in the UK exams and everything, they do not mention as a greenish discharge. They always give you in the scenario of a serous discharge. So this can be tested to you. Please try to understand. In the ductal ectasia, you can get a greenish discharge and you can also get a serous discharge. Now what is this particular diagnosis? So this is what you need to understand. This is what is your Paget's disease. Okay, what is this? This is a Paget's disease. This is a nipple areolar complex has been completely destroyed, and that is what is your Paget's disease. Okay, so yeah, diagnosis is the Paget's disease. It's usually unilateral. Nipple areolar complex is kind of destroyed. The characteristic thing is a biopsy. On the biopsy, what you're going to get is a Paget cells. Okay, so you get a characteristic Paget cells. Okay, so clear cells, that is what you kind of get over here. It is usually ERPR negative, CEA is kind of positive, and the 70% of the cases may have an underlying palpable lump. So when you kind of get a biopsy done, it might kind of come to you as a malign kind of lesion, and you will have to perform a modified radical mastectomy. Now this image is again very, very important. What is the diagnosis over here? So this is what is a Phyllodes tumor. What is this? This is a Phyllodes tumor. So how will you kind of diagnose this as a Phyllodes tumor? So this is basically having this bumpy appearance. Are you understand my point? So it when you basically look at it, it basically like appears like a bumpy appearance. Okay, so I hope you are able to understand this particular thing. Right. Okay. Just give me a minute. I'll just take one question. And underlying malignancy Paget's. Okay. So yes, in the Paget's, the underlying malignancy is usually an invasive ductal carcinoma, but it's not like that every time you're going to have a malignancy. Sometimes you can also have a benign kind of a state. Okay, so that's what you need to understand is you have to kind of first do a biopsy, and then you have to kind of figure out whether there is a malignancy which is present there or not, or something like that. Okay, so I hope you have understood this point. Okay, now what I'm talking about over here is a Phyllodes tumor. Okay, so this basically, in the gross appearance, it basically looks like this, poculated and everything, and on the surface of it, you have like the veins and everything are a bit dilated and everything, all this. That's fine. Now when you basically go and examine this particular patient, what you need to understand, this particular tumor is free from the chest wall. So it is not attached to the ribs and everything. It is attached to the pectoralis major, but what we have learned that pectoralis major involvement is not the kind of involvement of the chest wall. Now it is a benign kind of a lesion, but it has a malignant potential. So it may turn into a malignancy in, let's say, 5 to 10% of the patients, but it is usually a kind of a benign kind of lesion. Okay, that's fine. Now the treatment is either wide local excision or the simple mastectomy. That's all fine. Why is it called as a phyllodes? Because on the histopathology, it basically appears leaf-like. Okay, it basically appears leaf-like. Okay, right? I hope you are able to understand the point. Okay, it doesn't involve the nipples and the skin overlying it and everything. Okay, that's all fine. So this is all about the breast, which we talked about, guys. Okay, so this is you can just kind of okay, I'll just kind of talk a bit about this. So what is this? This is basically a QR code which will lead you to my number if you wish to kind of, I also run a kind of WhatsApp group. The link of that you will find in the description box, or you can kind of text me so that I can add you to that particular group. This is what is a YouTube channel which I'm kind of taking this particular session on. If you have not subscribed yet, please consider subscribing it. Lastly, if at all you wish to connect with me on the Instagram, you can kind of follow this particular stuff. It's not that active now, but it's going to be active in a couple of days or so. Okay, so that's all. Now we'll be going to talk about the trauma. But before we talk about the trauma, again, I have to kind of charge this particular pencil for a couple of minutes. Okay, so sorry for that. I don't know why I screw with this particular thing every time, but yeah, just pardon with me. Just stay with me for 1 minute. I'll just charge it and we can have a word. If you wish to ask me something in the comment box, anything, please do ask. Okay. Yeah. So guys, yeah, just give me 1 minute for that particular pencil to get charged or something. Okay. Till then, let's kind of talk about you. How are you guys doing? I hope you guys are doing good. All of you are doing great. Not getting scanned QR code. Which QR code is not getting scanned? So my college is, which college? MBBS, MS, or my urology? I've also completed my urology. So basically I completed my MBBS from MGI MS Sevagram, Vardha. Okay. Then I did my MS from GMC Surat, and I have done my urology from Delhi, from Max. I just completed it a couple of months back. Right. I have been teaching for like last 5 years on and off. In between, I was associated with the recorded platforms. I was a full-time educator in academy as well, few years back. Enough of me. So high on anxiety. So you're high on anxiety, Satyaja. That's kind of, I am from, okay. So we'll talk about anxiety. We've talked about anxiety a bit yesterday, but we'll talk about this. So again, everything boils down to same thing, right? Okay, so it really doesn't matter, right? I mean, what's the use of getting super anxious at this point of time? Is it going to change anything? No. Yeah, it's going to actually change something. If at all you get super anxious, your performance will actually get kind of a bit lower. Okay, so don't get super anxious. Some amount of anxiety is good, some amount of anxiety is okay, but yeah, like don't be super anxious. Now it's very easy for me to just sit over here and say this. I understand it's a bit difficult to kind of implement it on ground, but for that you have to fall back to your close friends, you have to fall back to your family, basically your inner circle. Like I'm pretty sure that, I hope that everybody has some 3-4 people in their inner circle, and you have to kind of fall back to them who are basically truly wanting to see you win. Just fall back to them, just put your all guards down, just talk to them, and then you'll be fine. Okay, and I understand that there are so many things which you have not read, there are so many things which you are going to screw up on the day of the exam, but that makes you human, right? So it's all okay. With whatever you have read, with whatever the kind of knowledge you have, just go and just try to give your best, and let's see what happens. Okay, so nothing to be over anxious about. I understand it's very easy to say over here, but I have crossed that and I have come on the other side as well. So believe me, all the negative thoughts and all the worst circumstances which we kind of imagine in our mind, they're not worth it, and 99% of the times they're not true. So it's okay. Just relax, just calm down, just take a deep breath, just talk to your true friends or whatever, the core circle, inner circle, whatever, and just make sure one thing, that whatever you have read, whatever you know, just decide that you're not going to kind of screw up in that. What you don't know, it's absolutely fine. But what you know, if you screw up on that, that is what is going to be a very big thing, very bad thing. Okay, so yes, I'm pretty sure that you will kind of do that. Sir, on reading, I become zombie mode. How to overcome that? Okay, so what about the zombie mode? There's nothing like a try to understand. It's humanly not possible to kind of read for 16, 18, 20 years for a prolonged period of time. So just maintain a decent amount of 12 to 14 hours of kind of reading. That's going to be good enough. And another important thing is, I'm pretty sure that might be happening with you guys as well. If you sit for, let's say, 4 hours or 5 hours or something like that, make sure that the effective output is at least 3.5 to 4 hours or something like that. I've seen so many times, and at times I've experienced this with myself as well. You sit and do the work for, let's say, 4-5 hours or something, but the effective outcome is much lesser, let's say half an hour, 1 hour or something like that. So it's always a day to kind of make yourselves better. That's all fine, but have sustainable kind of goals and everything. So that is something which is kind of advisable. So yeah, that might help you kind of overcome these particular things. Okay. Where I am from, I'm basically from Nagpur. My hometown is basically Nagpur. Okay. Yeah. So I think it's charged now. I'll just attach it. Otherwise you will say that, you know what, sir, what's up, bed? Can I gup shup karo? No. Let's kind of get back to the studies and we can talk. Okay. Once your exams are over, I'll be kind of active over here and then we can kind of connect regularly and talk or something like that. Okay. Yeah. So for now, let's try to kind of help you for this particular exam with whatever the bit I can. Okay, now in the trauma, what I will start with head injury. Okay, let's start with the head injury. Okay, so in the basics of the trauma, what you should read, I'll just kind of cover that. So, okay, so what about this? If I ask you that according to the ATLS, now what you have is this C, A, B, C, D. So what does this C basically stand for? C basically stands like, what is this particular C? This is not for the cervical spine. This is basically control of an external hemorrhage. Okay, so please try to understand what is the C. C is basically control of an external hemorrhage. So let's assume that there is a patient who is coming and there's a bleeding which is happening from the hands, legs, whatever. Then this particular C is basically control of that particular hemorrhage. Okay, then A, B, C, D. A is airway along with the cervical spine. Yeah, I hope that you know the definitive airways and the non-definitive airways and everything. If at all there's a severe maxillofacial injury, what is the emergency airway of choice? It is a cricothyroidotomy. But what is a definitive airway? It is a tracheostomy. Okay, so I hope you have understood this point. What about the nasotracheal intubation? Severe maxillofacial injury, nasotracheal intubation is contraindicated. Why? Because there is a chance that the base of the skull might also be fractured, and if at all you perform a nasotracheal intubation, your nasotracheal tube might go into the brain and it might injure that particular brain parenchyma. So that is why it is contraindicated. What about the orotracheal intubation? A single gentle attempt can be tried. Breathing, it's all okay. Circulation, what you need to understand is that we are trying to kind of reduce the use of the crystalloids in today's time. So earlier it was like we have to give 2 liters and everything. Now we basically restricted to 1 liter, and then we try to kind of go back to what you call as a blood. Okay, so obviously as soon as possible we try to give the blood and the blood substitutes and everything like that. Okay, now according to the trauma transfusion guidelines, what is the ratio? Like if at all you have to give the patients a massive transfusion, or in trauma transfusion guidelines, what is the ratio in which you have to give the RCC is to the platelets is to the FFP? It is 1:1:1. Why this is being done? In order to reduce the risk of coagulopathy. Okay, so because you want to reduce the risk of coagulopathy, and that is why what you basically do is you give the red cell concentrate, it's to FFP, is to the platelets in the ratio 1:1:1. Okay, now disability is basically the GCS. We'll talk about it I think in the head injury, and then that's all fine. Okay, then log roll and everything you should kind of know that. Okay, now let's kind of come to the head injury. Now in the head injury, what you need to understand, there's a base of the skull fracture. Now what is this particular base of the skull fracture? So here there's an anterior cranial fossa fracture and the middle cranial fossa fracture. In the anterior cranial fossa fracture, there is a CSF rhinorrhea which basically takes place, which is basically the CSF which is basically dripping from that particular nose and everything, and there is a black eyes, that is a raccoon eyes, which can happen in these particular patients. Now for the CSF rhinorrhea, what is the best investigation to diagnose this particular CSF rhinorrhea? It is beta-2 transferrin. Okay, so what is it? It is a beta-2 transferrin. Okay, so that is what you need to understand. Then what we have is in the middle cranial fossa fracture, there is a CSF photoria, that is CSF which is coming from the ears. Then we have hemotympanum, that is when you do an otoscopy, what you basically find is that there is a blood which is accumulated behind the tympanic membrane, and then there is a battle sign. What is this particular battle sign? Here there is an ecchymosis on this particular mastoid process, and if at all there is an ecchymosis in the mastoid process, what you need to understand is it is not the, sometimes the students mark mark it as an anti-agglomerular fracture. No, it is basically a battle sign, and it is basically a middle cranial fossa fracture. Okay, so these are the images which you can see. This is what is a battle sign, and over here what you're basically seeing is a raccoon eyes or the black eyes or whatever you want to call it. Okay, now there's something which is called as a subconjunctival hemorrhage. Right now, the subconjunctival hemorrhage can also occur. Now, this is something which I'll just cover it with you guys. So how do you kind of, okay, so let's assume that you got angry with me and you came and you kind of punched me in the eyes or something like that. What's going to happen? There's a chance that some subconjunctival hemorrhage may happen over here. So how do you distinguish whether that particular subconjunctival hemorrhage over here is because of the direct trauma to the eyes, or it is because of the base of the skull fracture? Okay, so how do you kind of distinguish that? So please try to understand this particular point. You ask the patients to kind of look laterally. Okay, so you basically try to look for the posterior aspect of that particular hemorrhage. Okay, so the upper and the medial aspect of that boundary of that particular hemorrhage. If you are able to see that, then it is basically a direct trauma to the eyes. But if at all you're not able to visualize the upper or the the medial or the superior boundary of that particular hemorrhage, it basically means that probably it is because of the base of the skull fracture. Okay, I hope you have understood this particular point. Very important. Okay, middle will lead to the dural leak, leading to the temporal lobe contusion. Okay, so yes, I mean that's fine. Right, okay, got it. Right, self-resolving, no, not really. So obviously self-resolving to lig baat hai, but we are talking about the diagnosis. When the patient is coming to you, immediately how will you kind of suspect the base of the skull fracture or something like that? Now what is this? This is okay. So what is an investigation of choice whenever there is a patient who is coming to you with a head injury or something like that? What is the investigation of choice? Investigation of choice is a non-contrast CT scan of the head. Okay, now what you need to understand is that every patient after the trauma, you will perform this particular non-contrast CT scan of the head. Every patient. No, right? No. So there are few guidelines for that. So what are these particular guidelines? These are the NICE guidelines. Okay. So this is a list of the things in which you will perform that particular CT scan, non-contrast CT scan of the head within 1 hour. So what are these? If at all the GCS is less than 13, GCS is less than 15 at 2 hours. So at the time of the admission, probably it was, let's say, 14. But after 2 hours, what you have is you have the GCS of 14 itself. It has not recovered to kind of 15. Okay, then open or the depressed skull fracture, any sign of the base of the skull fracture. So how will you suspect that? We just saw, right, hemotympanum and whatever, like CSF otoria, CSF radiuria, raccoon eyes, all those particular things. If at all the patient has, then you will suspect that, you know what, there is a base of the skull fracture. Then post-traumatic convulsion. So if at all, let's say the patient is basically saying that after the trauma, the patient had a seizures or convulsions or something like that. Focal neurological deficit. What do you understand by the focal neurological deficit? Focal neurological deficit means that the trauma has happened and now the patient is not able to move the legs or the arms or something like that. Then more than 1 episodes of vomiting. Okay, so all these particular things are the indications of doing a CT scan within 1 hour. Very important. Okay, then these are the things which are basically in which you perform a CT scan within 8 hours. Now why on earth within 8 hours? Because see, try to understand this point. So I do not have a lot of time, I'll not be able to explain you in a much detail, but what you need to understand is that let's assume that there is an extreme of the age, very old age. So in the old age, what you have a risk of something which is called as a chronic subdural hematoma, chronic SDH. There's a risk of that. Why is there risk there? Because the brain has atrophy. Now what you need to understand, the mobility of the brain inside the skull is a bit more. So even a trivial trauma, let's say falling from this particular chair, it might be considered a trivial trauma, very small trauma. So even a small trauma can actually lead to the injury to that particular vessel, and because of that, what is going to happen? The bridging veins, and because of this, what you need to understand is the bleeding can kind of happen. Now if at all you perform a CT scan, let's say within 1 hour, what's going to happen? You might miss it because maybe it's a very small bead and it will take some time to kind of develop. So you have to wait for around 8 hours. So this is what you need to understand. Any patient above 65 years, even if there is a trivial trauma, you have to kind of get a CT scan done, but not within 1 hour, within kind of 8 hours. Not that much tested in the Indian exams, but in the UK exams, this has been tested quite a lot. Okay. Now, history of the bleeding and the clotting disorders, that's all fine. So if at all, let's say there's a patient who is saying that the patient was on the clopidogrel or the heparin or something like that. Okay, so that is what you need to understand. Now, dangerous mechanism of injury and more than 30 minutes of the retrograde damnation. Okay, now very good question. So Satyajay is asking, sir, chronic SDH investigation of choice is MRI, whereas acute SDH NCCT. Yes, absolutely right. Okay, so what you need to understand is why on earth do we perform a non-contrast CT scan? So let's kind of talk a bit of concepts over here. So why on earth do you perform a non-contrast CT scan? Blood appears white, yeah, that's what you will say. But if I do a CT scan of my hand, does the blood appears white? No, right? So let's assume that I have to kind of investigate for the liver trauma. What we order is contrast enhanced CT scan of the abdomen. Why on earth we do not order non-contrast CT scan of the abdomen? So please try to understand this particular point. If at all there is an acute extravasated blood, okay, acute extravasated blood, it has some paramagnetic properties because of which that appears white on the non-contrast CT scan. Acute extravasated blood. In the chronic SDH, already the 21 days have happened, and because of this, what you need to understand, you will not be able to very well distinguish between the normal parenchyma and the chronic SDH accumulated blood, and that is the reason why in the chronic SDH, when the patient is basically coming after 21 days, then the investigation of choice is an MRI, because it's not like that CT scan will never ever pick it up. It may pick it up, but it can miss it also. So that is why when you suspect that the patient is basically having a chronic SDH, then you basically have to get an MRI done. But there can be another possibility that somebody was very vigilant and there was an old person, let's say within 12 hours, even if the patient's GCS was fine, the patient got a CT scan done after 8 hours, and then there was a small bleed which was picked up and it was investigated and it was kind of dealt with in a proper manner. You understand my point? In that case, you will prevent the chronic SDH from happening. I hope you have understood. I do not have a lot of time, so that's why I'll not be able to explain it any further, but I hope you have understood the gist of what I was trying to tell you about. Okay, now this is not the perfect time, but what I want to kind of convey, if at all, let's say you are not the one who are preparing for this particular NEET, and if at all you, let's say, you're preparing for the next year or something like that, or let's say you're an undergraduate student or something like that, whenever you read any particular topic, please read it with a bit of a concept. We just try to mug these particular things up, that's going to be a really difficult thing to be done. Okay, so I hope you have understood this particular point. So yeah, always kind of focus on the concept and just try to kind of think that how I can understand the crux of this particular topic, because in the textbook there are so many things which are kind of written, but what is important is a very few points about that or something like that. Okay, so yeah, let's kind of get back to our mission, what we're trying to do over here, and we will interact with you guys over a period of time, let's say after this particular NEET PG as well. Now, the two most important kind of head injuries which we have is the EDH and the SDH. Why does the EDH occur? It is because of the injury to the middle meningeal artery. So what happens is the trauma happens, there is a pterion. What is this particular pterion? Pterion is the thinnest part of the skull which we have. Just below this particular pterion, which is H-shaped suture, just below this what you have a middle meningeal artery which is running. So what can happen is that middle meningeal artery can get ruptured, and because of this there can be blood which is going to get accumulated between the skull and the dura mater. This is what is called as an EDH, that is an extradural hematoma. Okay, I hope you have understood this point. Now, the lucid interval is something which is most commonly associated with the EDH, but it can be associated with the other things as well. Okay, on the CT scan, investigation of choice is obviously going to be a non-contrast CT scan. And if at all you don't know this particular image, please get this. I'm pretty sure that most of you guys are aware of this. What is this? This is a biconvex opacity, or the lemon-shaped opacity, or what you call as a lens-shaped opacity or something like that. So this is what is basically going to be diagnostic of extradural hematoma. I'm pretty sure all of you kind of know that. Okay, right? Okay, now what about the management? So if at all there is a midline shift, as you can see over here, there is a midline shift, then what you can do is you can perform a burr hole. Burr hole is a management for this particular stuff. Okay, now very important thing. So let's assume that there is a patient who is basically coming after the head injury, and what is going to happen to the pupils? The pupils are going to be dilated, or the pupils are going to get constricted. Okay, so can you please help me with this? Okay, so what is going to happen? Because of this particular EDH, the pupils are going to get dilated. Okay, so fixed dilated pupils are going to be kind of there. Okay, so that is what you need to understand over here. So let's assume that let's say there is a patient who is coming to you after the head injury, and the patient's right pupil is basically dilated. So where are you going to perform the burr hole? CT scan is not available. Whether you will perform it on the right side or the left side. Okay, so you'll perform it on the right side. So ipsilateral pupils are dilated and the contralateral limb weakness is there. So in the EDH, what you basically get is an ipsilateral dilated pupil and the contralateral limb weakness. Okay, so please try to understand this particular point. Okay, now if at all both the pupils are dilated, then what you're going to do? Some students said that, you know what, do a burr hole in the middle. No, not really. You will enter into the cavernous sinus. Okay, so like you will enter into the superior sagittal sinus. Okay, so sinuses are going to get open. Obviously not. So what you're going to do, if at all the bilateral dilated pupils are there, then you have to do a bilateral burr hole. Okay, so please try to understand this particular point, guys. Okay, now then what you have is an SDH. What is this SDH? So this basically happens because of the injury to the bridging veins. Okay, so you have a bridging vein. So what happens is there is a curve, counter curve, and like, so what you need to understand, inside the skull there is a brain which is kind of there. So when there is a trauma, there is a traction to these particular bridging veins. So because of this, they may get ruptured, and there can be the blood which is going to get accumulated between the dura mater and the arachnoid matter. So this is what is called as a subdural hemorrhage. Okay, so this is what is a subdural hemorrhage. Now what you need to understand over here what you basically get is a concavo-convex opacity. What you basically end up getting is a concavo-convex opacity. So that is what you need to understand over here. And yeah, that is what is your like EDH, extradural hematoma. Okay, now if I just show you this particular image and if I ask you what kind of an head injury is there, this has been asked to you once. Okay, so what is this? This is what is a what you call as a what it's a cerebral contusion. Okay, so what is this? This is what is a cerebral contusion. So what you're able to see over here, so you are able to see that this is what is a heterogeneous collection. So are you able to appreciate these particular white things? Why are they white? Because it is an acute extravasated blood. So whenever there is a contusion, what you need to understand, there is a bleeding and there is a edema also. So in this particular part of the brain, what you're basically having is you're having a bleeding and there is a edema as well. So what is this? This is what is a cerebral contusion. Why does this particular happen? This basically happens because of the Kaup counter-Kaup mechanism. Okay, so when the injury, like whenever there is a like a stagnation of whatever the vehicle or something like that, the brain parenchyma comes and hits the skull and then it basically bounces back. So this is what is called as a Kaup counter-Kaup mechanism, which you basically get in these particular patients. Okay, right now over here, how are you going to manage these particular patients in the cerebral contusion? The management is basically conservative. So what you're going to do, you're going to kind of reduce the intracranial pressure in these particular patients. So that is what is a management. But if at all, let's say the pressure has increased a lot, then you will have to kind of perform a decompressive craniotomy. You'll have to kind of remove a part of the skull and then you'll have to kind of perform a decompressive craniotomy over here. So that is what you need to understand over here. Then you have a subarachnoid hemorrhage. In the subarachnoid hemorrhage, what is the most common cause of a subarachnoid hemorrhage? Is it like a rupture of a perianeurysm or it is trauma? So please try to understand the most common cause of the subarachnoid hemorrhage is basically trauma. Trauma is much more as compared to the rupture of the perianeurysm. Okay. Now, when we talk about the clinical features, what you need to understand, the patients are going to say that there is a severe headache and there are the signs of the meningeal irritation. So so they are going to say that there is a thunderclap headache. What on earth is this particular thunderclap headache? Thunderclap headache basically means that the headache started and within seconds it basically rose to the maximum peak. So this is what is referred to as a thunderclap headache, and they're going to say that this is the worst headache of their life. So these are the things which they are going to say. Now there are the signs of the meningeal irritation. So in the subarachnoid hemorrhage, you're not going to get a focal neurological deficit. What are you basically going to get is vomiting and the neck rigidity. So all these particular things you're going to get, which are basically the signs of the meningeal irritation. These particular meninges are getting irritated, and because of this, you're going to get this. Investigation of choices. I'm really sorry for this. It is not a contrast enhanced CT scan. It is going to be a non-contrast CT scan only. Now, what you're basically going to get over here is this is what is referred to as a Dawson's fingers or something like that. Are you able to appreciate this? This is what is a contrast which is basically going into the sulci and the gyri. But that image is not important. That's all fine. The management is conservative. Again, like the mannitol and all those particular things you have to kind of give to these particular patients. Diffuse axon injury. What are you going to get in this particular diffuse axon injury? So they are going to say that there's a patient who came to after road traffic accident. The GCS of that particular patient is, let's say, 8/15 or something like that, and then you send the patients for a non-contrast CT scan, and the non-contrast CT scan came out to be normal. Okay, now what is the diagnosis of this particular patient? The diagnosis is diffuse axonal injury. So what happens is that in the diffuse axonal injury, there is an angular force, and because of this, there are multiple punctate hemorrhages which basically occur at the junction of the gray matter and the white matter. So this is what is about the diffuse axonal injury. Okay, now here what you need to understand is the patients land up into a persistent vegetative state, and yes, absolutely right. The diffuse axonal injury is the one which is having the worst prognosis. Which is the one which is having the best prognosis? Which is the one which is having the best prognosis? So EDH. EDH is the one which is basically having the best prognosis. Okay, so EDH is the one which is having the best prognosis. Okay, right. Now, whenever you are dealing with the patients with a kind of a head injury and everything, we are always trying to kind of reduce the intracranial pressure. Why on earth? Because we want to maintain this cerebral perfusion pressure. So what is this particular cerebral perfusion pressure? This is the pressure which is needed for the blood to kind of reach to the brain parenchyma, right? So in our heart basically pumps the blood, but the heart, like that particular blood has to kind of overcome the intracranial pressure in order to kind of reach to the brain parenchyma. So how do you kind of calculate the cerebral perfusion pressure? Mean arterial pressure minus the intracranial pressure. Okay, so cerebral perfusion pressure is mean arterial pressure minus the what you call as the intracranial pressure. Now, if at all there is a head injury, what is going to happen? The intracranial pressure is going to kind of rise. Normal is, let's say, 5 to 15, but if at all it basically keeps on rising, what is going to happen? The cerebral perfusion pressure is going to kind of come down. When the cerebral perfusion pressure comes down, there's going to be the ischemic injury to the brain. And if at all the intracranial pressure keeps on rising over a period of time, there's going to be the brain herniation. So in order to prevent all these particular things, what you basically try is, we try to kind of bring the intracranial pressure down with the help of medical therapy. Let's say the osmotherapy, or like we give mannitol, we give whatever, we elevate the head, we do hyperventilation and all those particular things. But if these things do not work, then you have to perform a decompressive craniotomy. And if obviously if at all there is an EDH or SDH or something like that, we'll have to evacuate that particular thing. Okay, so I'm just giving you, I've just been able to give you the gist of a head injury, guys. I'm pretty sure that okay, obviously it was not in that much of depth and everything, but if you have any particular doubt which is specific to the head injury, please put it in the comment box as well. It's very difficult for me to cover everything in depth, guys. Okay, I hope you have understood this point. All I'm trying to do over here is brush up kind of things for you guys. Okay, so I hope it's kind of helpful to you. If not, then you can just kind of put it in whatever the chat box or something like that. And if at all you have any suggestions, I'll try to incorporate that in the next couple of sessions or something like that. Okay, but for now, if you have any doubts in whatever the topics we have covered today, please put it in the chat box. I'll try my level best to kind of address them. Now, moving on to the thoracic trauma. In the thoracic trauma, the two things which you really need to understand is the hemothorax and the pneumothorax. Now, how do you kind of distinguish between them? So very simple, but I'll just kind of cover it kind of over here. So what you need to understand is that, let's say, assume that there is a patient who's coming to you with a respiratory distress. Okay, then they're going to say that, you know what, when you examine that particular patient, the trachea was deviated to the opposite side. So let's assume that the trauma was on the left side of the chest and the trachea is deviated on the right side. And then they're going to tell you that you took a stethoscope and you tried to auscultate the chest, but you are not able to hear any breath sounds on the left side. Okay, now comes the time of the percussion. So till here, that is respiratory distress with the trachea deviated to the opposite side with the absence of the breath sounds on the same side. These particular findings are going to be the same for the hemothorax and the pneumothorax both. These particular findings are going to be the same. In the percussion, if at all they mention that there is a hyper-resonant node, then it is a pneumothorax. In the percussion, if they mention that there is a dull node, then you are probably dealing with a hemothorax. Okay, I hope you have understood this particular point. Now, in the what you call as a pneumothorax, in the pneumothorax, which you need to understand is the X-ray will be something like this. Okay, what is this? So what is this, guys? What is this? This is what is a collapsed lung. And I hope you're able to appreciate that this particular part of the lung appears more black as compared to this. Now again, this is one of the very simple like images. I'm pretty sure you guys must be knowing, but if you don't, please try to understand this. Okay, so this particular part appears more black as compared to the opposite side. Why so? Because the lung has collapsed. So whatever the bronchovascular markings are there, they're not there. So this is what is an X-ray of a pneumothorax. Okay, this is what is an X-ray of a pneumothorax. Now what you need to understand is in the pneumothorax, there are also two types. One is the simple pneumothorax and another is a tension pneumothorax. Now in the tension pneumothorax, what happens? There is a flap valve. Okay, so there is a flap valve. So what you need to understand about this particular flap valve, whenever there is a valve is something which is going to allow the flow only in one direction. So in the simple pneumothorax, what happens? That is the air enters into the thoracic cavity and it can also leave the thoracic cavity. But if at all there is a flap valve, what is going to happen? The air will only be able to enter into the thoracic cavity. It will not be able to leave the thoracic cavity. Okay, so over a period of time, what is going to happen? That is the pressure inside the thoracic cavity is going to rise, and that is what is going to create two things. One, hemodynamic instability, and the neck veins are going to get distended. Okay, so how do you distinguish? You should be able to appreciate the difference between the simple pneumothorax and the tension pneumothorax. Respiratory distress, trachea deviated to the opposite side, absence of the breath sound on the same side, and on the percussion hyperresonant node. Along with this, if they also give you that there is a hemodynamic instability and there is a distended neck vein, so the raised JVP, then they are probably talking to you about the tension pneumothorax. I hope you have understood this particular point. Now, what is the management of a tension pneumothorax? The emergency management is that you have to kind of insert a wide bore needle. Where do you want to insert this particular wide bore needle? In the children and the adults, it is a bit different. In the children, you put it in the second intercostal space in the mid clavicular line. In the adults, you basically put it in the fifth intercostal space in the mid axillary line. Do not forget this. Okay, so in the children, you put the wide bore needle in the second intercostal space in the mid clavicular line. In the adults, you basically put it in the fifth intercostal space in the mid axillary line. This is about the like emergency management. The definitive management is putting an ICD. That is basically done in the fifth intercostal space in the mid-axial line. Okay, right. Now I'll just cover the hemothorax and then I'll take one question. I think I can see there's one question over here. So what is the hemothorax? Hemothorax is basically presence of the blood inside this particular thoracic cavity. As I mentioned to you on the percussion, what you're going to get is a dull note. Okay, so this is what is a like an X-ray of a probability of a hemothorax. It also can be pleural effusion. So that is why if you want to diagnose it surely, you'll have to put in needle and you have to kind of aspirate. On aspiration, if at all you get blood, then that is a confirmation that you're dealing with a hemothorax. Now, if at all you're dealing with the hemothorax, how you're going to manage it? You have to put an ICD. Where do you put an ICD? Fifth intercostal space in the mid-axial line. You put an ICD, job done. Can we go home? Can we all go home? No, not really. So after you have put in an ICD, you have to observe these particular patients. Why? Because now I'm trying to ask you the indications of a thoracotomy, right? So if at all once you put in an ICD, there's something which is called as a stat output. What is the stat output? Immediate output. So if at all the immediate output from this particular ICD is more than 1.5 liters, if at all you're dealing with a blunt trauma, or if the immediate output is basically more than 1 liters, if you're dealing with a penetrating trauma, take the patients for a thoracotomy. There's some very significant injury which has happened inside the thorax. Or if at all, let's assume that the immediate output was 800 ml. Okay, you were like, okay, no issues, we'll observe. So if you observe, and if at all every year, if at all the output is more than 200 ml for 3 consecutive hours, okay, so every year the output is basically more than 200 ml for 3 consecutive hours, then also you are basically this is again an indication of a thoracotomy. Very important. I hope you have understood this point. Okay, so stat output of more than 1.5 liters in case of a blunt trauma, stat output of more than 1 liter in case of a penetrating trauma, or if at all the output is more than, let's say, 200 ml per hour for 3 consecutive hours. So all these are the indications of performing a thoracotomy. Okay, so this is all about the pneumothorax and the hemothorax, which we have to kind of talk about. Okay, now I'll just take one question. I think there's one question over here. Hemothorax needle insertion, where tension pneumothorax will have ICD, also management depends on the sinuses. So like ICD in this, no, not really. See, Satyaja, every time there is a tension pneumothorax, the patients will have some amount of the sinuses. Now, why don't you directly put an ICD? Okay, you might be thinking that, why first put an white bore needle, then you put an ICD and all those particular stuff. ICD is going to take some time. So let's assume that you are the best trauma surgeon in this particular entire world, but let's assume that you are in a mall where this particular tension pneumothorax patient is there. You cannot put an ICD over there. You do not have an ICD, you do not have all those particular stuff, but you do have a white bore needle, right? So any particular pen, you can just move the referral of that or something, and you can directly put it in the second intercostal space. You understand my point? So that is why it is an emergency kind of procedure. Let's assume that you are in the trauma center as well. It will take you more time to put an ICD, but just putting a white bore needle is relatively faster. Okay, so emergency management is a white bore needle. Sinuses, some amount of that is going to be there if at all there is a patient with a tension pneumothorax, and if at all already, let's say, some amount has kind of passed by, sinuses is going to be there. So presence or the absence of the sinuses is not going to decide whether ICD has to be put or not. Yes, if at all you have a simple pneumothorax, that is the hemodynamic instability is not there and the distended neck veins are not there, then you will have to directly put an ICD in the fifth intercostal space in the mid-axial line. Okay, I hope you have understood this particular point, guys. Okay. Now, let's talk about the diaphragmatic injury. Now, I had shared this particular one of the questions on my group like very recently. I asked, what is an investigation of choice of a diaphragmatic injury? Okay, and the most common wrong answer which I usually get was the same answer which I got on my group. So what you need to understand is the most common wrong answer which the students end up saying is that X-ray. Okay, but that is not the answer. The answer is basically laparoscopy. So let's talk about this. Okay, so let's understand this particular diaphragmatic injury, right? So what happens is that when do you suspect it? Is it more common after the penetrating trauma or the blunt trauma? So diaphragmatic injury is much more common after the penetrating trauma as compared to that of the blunt trauma. Now, when do you suspect? Now, let's assume that there's somebody who has come with a penetrating trauma. Every time you're going to suspect that the diaphragmatic injury. Now, before that, let's talk about presentation. So most of the patients of a diaphragmatic injury are going to kind of come to you asymptomatic. Okay, so they are not going to have any respiratory distress or something like that. Okay, so when they come to you, they are absolutely asymptomatic. They are having a penetrating injury. Now, how on earth will you suspect that, these particular patients have a diaphragmatic injury or not? So that will depend on the entry point. So if at all that particular, whatever the kind of a wound or like that particular stab injury, if at all the entry point is basically between the nipple and the costal cartilage. Are you understand my point? If at all the entry point is between the nipple and the costal cartilage, then you say that, you know what, you are basically suspecting that the patient is having a diaphragmatic injury. Why on earth? Because what you need to understand is the diaphragm is not a static kind of structure. It keeps on kind of going into the dome shape, then it becomes flat, it goes to the dome shape, it becomes flat. So you don't know when the injury happened whether the diaphragm was dome shaped or flat. Okay, so if at all the entry point is between the nipples and the costal cartilage, you have to suspect that the patients are basically having a diaphragmatic injury. Okay, are you understand my point? So what is the investigation of choice? It is not an X-ray, because most of the times the defect is very small. There is no herniation. X-ray will be able to diagnose it only when the intestinal organs have herniated into the thoracic cavity. Most of the times your patients are asymptomatic, the defect is very small, there's no herniation of the bowel, X-ray is definitely going to miss it. Even the CT scan is not that helpful. So investigate, and in the exam, if at all you don't know this particular answer, another answer which students tend to mark is an MRI, because the radiologists always kind of bombard our brains like, you know, for the soft tissue, investigation of choice is an MRI and all those particular stuff. In sitting in the examination hall, you will think that, you know what, diaphragm is in soft tissue. MRI is in one of the options. Let's kind of mark an MRI. You understand my point? So that's not the kind of correct answer. Please try to understand this particular point. So investigation of choice is a laparoscopy. Now there is another thing which is called as a VATS. What is VATS? Video assisted thoracoscopy. So I'll tell you what you basically do in this. You put a kind of a endoscope into the thoracic cavity, and then you basically look inside, right? Now even this will be able to kind of diagnose your diaphragmatic injury. This will also be able to treat your diaphragmatic injury. You can take the sutures from that as well. Then if at all both are there, laparoscopy and VATS, will you prefer VATS or laparoscopy? So please try to understand, even if both are there in the option, you will still prefer a laparoscopy, because the laparoscopy will help you rule out any other intra-abdominal injuries. Are you understand my point? So how on earth are you so sure that the knife which basically, or whatever the sword which entered, it has injured only the diaphragm? It has not injured the underlying spleen or the underlying liver or something like that. Are you understand my point? So laparoscopy is the investigation of choice. First of all, obviously it is going to kind of help you diagnose. At the same time, it will also help you rule out other abdominal injuries. Okay, now if at all, let's say there is a diaphragmatic injury and the injury is very small, let's assume 1 into 1 centimeter or something like that. How many times have you had a small laceration? Did you every time go and take the stitches or something like that? No, not really, right? So in the diaphragmatic injury, let's assume that you're dealing with a very, very small laceration, 1 into, let's say, 0.5 centimeters or something like that. Very, very small laceration. Will you go ahead and take sutures, or you can kind of manage these particular patients conservatively? Can you please tell me this? Okay, so conservative management is never done in the diaphragmatic injury. Why? Because a laceration which you had probably in your childhood, something like that, you were able to kind of leave it like that and you just did the dressing because you were sure that this particular part is going to heal, right? But in the diaphragm, the healing doesn't take place. So over a period of time, what is going to happen? The defect, which is now very, very small, over a period of time, that particular defect is going to increase, and now the abdominal contents and everything might go into the thoracic cavity. So patients will come to you, let's say after 10 years or 8 years or so, and then they will give the history. You know, it's a long back, there was an injury, a stab injury which had happened. I had gone to the hospital, nothing was done and everything like that. You understand my point? So always and always and always you have to repair it. And how do you want to repair it? With an absorbable suture or a non-absorbable suture? You have to repair with a non-absorbable suture. So all these are the important points about a diaphragmatic injury. I hope you have understood this particular point, guys. Okay, got it? Okay, right. Now X-ray will have see, try to understand, Satya. I understand all those particular stuff, but that is what is going to happen. It cannot be an investigation of choice because the sensitivity of the X-ray is going to be much lesser. But when you perform a laparoscopy, you are actually able to see, you know, whether that particular defect is there or not. Every time those particular signs will not kind of occur. Okay, why directly invasive? Because you have to kind of diagnose these particular patients, right? There's no other way of kind of diagnosing it. I hope you have understood this particular point, guys. Okay, right? Okay, now let's talk about the abdominal trauma. Now, the three of the very kind of most commonly asked and whatever thing. Most common organ injured in the blunt abdominal trauma, that is going to be the spleen. Most common organ injured in the penetrating abdominal trauma. Overall, that is what is going to be the liver. But if at all they are specifically talking about the gunshot injury, then we are dealing with the small intestine. Okay, so we are starting the abdominal trauma, guys. Okay, I hope you are okay with this, right? So let's move on to the abdominal trauma now. Okay, so these are the three important kind of one-liners. You definitely need to kind of remember them. Now, what is this FAST? So first of all, just remember, FAST basically stands for Focused Assessment Sonogram for Trauma. It is not basically what you call as Focused Abdominal Sonogram for Trauma. No, it is a Focused Assessment Sonogram for Trauma. Now, whatever you do in your life, you need to have some aim, right? So what is the aim of performing a FAST? The aim of performing a FAST is to basically look for intraperitoneal injury. Okay, so what is the aim? Aim is to look for intraperitoneal fluid. Okay, not injury actually, it's to look for intraperitoneal fluid. Okay, now you and I, do we have intraperitoneal fluid? Small amount, right? But let's assume that there is a patient who has come to you after trauma, and after the trauma the patient is basically having a significant amount of intraperitoneal fluid. What does it indicate? It basically indicates that some or the other significant injury has happened inside the abdomen. Okay, are you understanding my point? So what is the FAST? Focused assessment sonography for trauma. What you have to do over here, with the help of an ultrasound, your aim is just to look for intraperitoneal fluid. Your aim is not to comment on the appendix. Your aim is not to comment on whatever the gallbladder stones or something like that. Your aim is to just tell whether the intraperitoneal fluid is present or not. Now, how much amount of the fluid can be detected by this particular FAST? So 100 to 150 ml. So this is important. How much amount of the fluid? 100 to 150 ml of the fluid can be detected by this particular FAST. What you basically do is, it is basically a ultrasound which is done in the emergency room. This is basically completed in, let's say, around 3 to 5 minutes. You basically complete this particular procedure. What you basically do is, you keep your probe at 4 positions. What are the positions? Epigastric region, right hypochondriac, left hypochondriac, and the pelvic region. When you keep it in the epigastric region, you basically are ruling out what you call as a cardiac tamponade. In the right hypochondriac region, you are basically ruling out any kind of fluid which is accumulating around the liver. In the left hypochondriac region, you're basically ruling out any fluid which is accumulating around the spleen, and in the pelvic region, you're basically kind of ruling out whether there is any fluid in the pelvis or not. With the FAST, you are not able to comment on the lungs. So for this, what we came up with the E-FAST. What is this E-FAST? It is an extended FAST. In this, what you basically do is, you keep the probe at 6 positions. So along with these particular 4s, you also keep the probe at the right and the left lung field. Okay, so you also keep the probe in the right and the left lung fields. Okay, so I hope you are able to understand this particular point, guys. Okay, so you also keep the probe in the right and the left lung field. Now you can get something which is called as a seashore sign. What is this particular seashore sign? In the seashore sign, what happens is that the lungs basically expand, they come and hit the thoracic cavity, and then they basically go back. So these are the ones which are basically present in the normal individuals. And then what we have is a barcode sign or a stratosphere sign. What is this particular barcode sign or the stratosphere sign? This is basically present in the pneumothorax. Okay, so what is the what you call as importance of this particular, like what is this particular barcode sign, stratosphere sign, everything? So what you need to understand is that air is basically going to create an artifact in the ultrasound. Okay, so ultrasound and the air, they do not go hand in hand. Whenever there is an air, kind of artifacts are created. So yeah, because of all those particular artifacts which you basically see on an ultrasound, we get this particular barcode sign or the stratosphere sign in the patients with the pneumothorax. I hope you have understood this particular point. Now there's also something which is called as a diagnostic parietal lavage. Let's not go into the details of it. So this was done earlier quite a lot, and today's time it is done very, very rarely. So the purpose was the same. What was the purpose? Purpose was to look for intraperitoneal fluid collection. So what you basically do is, you put in a catheter through, like from the infraumbilical region, you put it, you direct it towards the pelvic cavity. Then what you do, you put 1 liter of the saline from this, you kind of keep it over there, and then after some period of time, you aspirate 300 ml of it, and then you send it for the microscopy. Now what you basically get in the microscopy, just 2 things you have to remember: RBCs and the WBCs. Okay, if at all, and only just remember this. Okay, if at all you get a RBCs of more than 10 to the power 5. Okay, so if at all you get an RBC of more than 10 to the power 5 on that particular aspirated kind of content, or the WBC of more than 500 kind of per ml. So this is what is your diagnostic of your diagnostic parietal lavage. And if at all the diagnostic parietal lavage is positive, then again the same thing is there, that there is some or the other significant intra-abdominal injury which has happened, and then you have to kind of operate on these particular patients or something like that. Yes, retroperitoneal fluid cannot be detected by the FAST. For that, the best investigation is contrast and CT scan. For any retroperitoneal injuries, for example, the pancreas and everything, what you basically have to look for is a contrast and CT scan. Now, this is very, very important. I'm pretty sure you guys would have gone through this, but let's kind of understand this. Management protocol for a blunt abdominal trauma. Okay, so let's kind of understand this. Okay, so whenever you have a patient with a blunt abdominal trauma, So what is the first thing which you're going to do? What is the first thing which you're going to do? Please remember this, okay? They have tricked you with this a couple of times, okay? So whenever you get a patient with a blunt or a penetrating abdominal trauma, the first thing which you have to look for is a features of peritonitis, okay? So what you have to look for? Features of peritonitis. Now, can you please tell me what are the features of the peritonitis, what you're going to look for in the question? Okay, so many students say tenderness. No, it's not fast. Okay, so you have to look for the features of peritonitis. So it is not the tenderness, it is rigidity and the guarding. Okay, rigidity and the guarding. Tenderness is not a feature of a peritonitis. So whenever you have a patient of any particular trauma, the first thing you'll have to see is whether the patient is having peritonitis or not. Okay, so yes, Satya, that's what I'm talking about. Fever with the tenderness, nothing. It can happen with many patients. Rigidity and the guarding. So yes, recondite. Okay, so that absolutely right. So what you have is a rigidity and it's a very important concept. So I'll just give you an example of this. There's a patient who came to you after the road traffic accident. The patient's blood pressure is 120 by 80 millimeters of mercury. The pulse rate is 92 per minute and respiratory rate is whatever 24 per minute or something like that. On abdominal examination, the patient is having rigidity in the garden. What is the next step which you're going to do? Do not mark it as a contrast CT scan. Do not mark it as a fast. The answer is exploratory laparotomy, because on the examination what you have is a rigidity and the guarding. So if you have a rigidity and guarding, what you have to kind of do is you have to kind of go ahead and do a exploratory laparotomy. Okay, I hope you are able to understand this particular point. Now, once you have ruled out peritonitis, once you have seen that peritonitis is not present, then what you have to do? You have to look for hemodynamic stability. Okay, what do you understand by the hemodynamic stability? Hemodynamic stability means the blood pressure. If at all the blood pressure of the patient is less than 90 millimeters of mercury, then you basically say that the patient is hemodynamically unstable. But if at all the blood pressure of the patient is more than 90 millimeters of mercury, you basically say that the patient is stable. So if at all, let's say the patient is hemodynamically unstable, the blood pressure is less than 90 millimeters of mercury. Now what you're going to do? Now you are basically going to perform a FAST. Okay, focused assessment sonography for trauma. If at all that comes out to be positive, then you basically perform an exploratory laparotomy. But if at all the FAST comes out to be equivocal, not negative. If negative, then you will just observe. Equivocal means that the radiologist is trying to tell you that, I cannot comment on this. I cannot tell you whether the FAST is positive or not or something like that. So if at all the FAST is equivocal, then you basically perform a diagnostic peritoneal lavage. And if at all the diagnostic peritoneal lavage is positive, then you go ahead and do an exploratory laparotomy. I hope you have understood this particular point, guys. Okay. So hemodynamics, first thing is, patients with a trauma, blunt, penetrating, whatever, look for peritonitis. They will never tell you peritonitis directly in the question. What they're going to give you is rigidity and the guarding, right? Now, if at all the peritonitis is not present, then you look for the hemodynamic stability. If at all the patient is not hemodynamically stable, it means that the systolic blood pressure is less than 90 millimeters of mercury, then you basically perform the FAST. If at all the FAST is positive, straight away go ahead with the exploratory laparotomy, no other investigation needed. But if at all the FAST is equivocal, then you perform a diagnostic peritoneal lavage. If that is positive, then you go ahead with an exploratory laparotomy. But if at all the patient is hemodynamically stable, now you basically have a lot of time and everything. You've already checked for this peritonitis. Now you basically perform the CT scan and the FAST and everything. And the physician basically looking at the condition of the patient and whatever you basically get on the CT scan and everything, you basically decide whether this particular patient has to kind of has to be operated or has to be put on the conservative kind of therapy. Okay, so these are the 4 one-liners which they keep on asking you on this. So what is the first investigation? Okay, so what is the first investigation? If at all, first investigation and the investigation of choice. If at all you are dealing with a hemodynamically stable person, what you need to understand, the first investigation is the FAST and the investigation of choice is contrast enhanced CT scan. But if at all you're dealing with a hemodynamically unstable person, that means that the systolic blood pressure was less than 90 millimeters of mercury, the first investigation and the investigation of choice, both are basically the FAST. Okay, so I hope you have understood this particular point. Very important. Okay, now this is the management protocol of a penetrating abdominal trauma. Okay, now before this, I'll just kind of address guarding is due to tenderness. No, tenderness, guarding, rigidity, all three are the very different things. Okay, tenderness can be there because of a number of reasons. Guarding basically means that the muscles, abdominal muscles are being made tight so that when you press, the pain is not felt. Okay, so let's kind of go there. It's a very, very basic, but yeah, I hope you have understood. Just stick to the kind of MCQs over here. What you need to understand on the question, if at all they have written tenderness and the guarding and the rigidity, then it is basically they are telling you that you are having a patient with a peritonitis. Tenderness is basically can be presented in a number of places. Okay, now coming to the management protocol for penetrating abdominal trauma. Now this is again a very, very important topic. Okay, let's talk about this. So let's say you have a patient and you have patients with a penetrating abdominal trauma. What is the first thing you're going to do? You're going to see whether the patients are having peritonitis or not. If at all there is a peritonitis, nothing done, nothing doing, you have to straight away go ahead with an exploratory laparotomy. Let's assume that the patient is not having peritonitis. Now again, we have to see whether the patient is hemodynamically stable or the patient is hemodynamically unstable. So if at all the patient is hemodynamically unstable, here, no fast, nothing is needed. You straight away have to kind of go and perform an exploratory laparotomy. Did you understand this particular point? So what is the difference between the blunt and the penetrating trauma? In the blunt trauma, if the patient was hemodynamically unstable, you had to kind of what you call as perform a fast, and if at all the fast was positive, then you go ahead with an exploratory laparotomy. But in the penetrating abdominal trauma, if at all the patient is hemodynamically unstable, you need no other investigation, you straight away go ahead and do an exploratory laparotomy. Now this is basically like a redrawn version from your Schwartz guys. Okay, so this is very, very reliable. You can just go through it. It will help you a lot in kind of solving a lot of MCQs. So let's talk about that. Okay. Then hemodynamically unstable person, directly go ahead with an exploratory laparotomy. What about the hemodynamically stable person? Now there are the two ways in which these particular patients might have got injured. Okay, somebody would have gone and shot these particular patients, or there would have been a stab injury to these particular patients. So what you would have had is you could have had a gunshot wound. Okay, so gunshot wound, or there could have been a stab. Now in the gunshot wound, again it can happen to the anterior abdomen or it can happen to the back or the flank. So if at all there's a gunshot wound on the anterior abdomen, nothing doing, you have to kind of straight away go ahead with an exploratory laparotomy. So gunshot wound on the anterior abdomen, straight away exploratory laparotomy. But if at all, let's say other parts, it means let's say the back or the flank or something like that, gunshot wound, now you perform a contrast enhanced CT scan, and if at all that shows something which is positivity, then you go ahead and do an exploratory laparotomy. Everybody is clear till over here? In the patients with a penetrating abdominal trauma, gunshot injury, anterior abdomen, straight away laparotomy. But if at all it is to the back or the flanks, you perform a contrast enhanced CT scan. If at all that shows some positivity, then you perform a laparotomy. Now coming to the stab wound, somebody could have kind of come and stabbed that particular person or something like that. Okay, now again, if at all that particular stab wound is basically on the back or the flanks, okay, if at all there is a stab injury to the back or the flanks, contrast enhanced CT scan, if at all that is positive, then you go ahead and do an exploratory laparotomy. But if at all that, okay, now we'll talk about the anterior abdomen, just give me a minute. Okay, now let's assume that in the question, if at all they have given evisceration. What do you understand by evisceration? That is the intestine have come out and the intestines are basically present in the hand. Or let's say there is a bile staining of the cloth. It means that the bile is basically kind of stained the clothes. Okay, now obviously what does it mean? It means that the hepatobiliary pancreatic kind of system has got kind of injured or something like that. Or let's say if at all they say that the omentum is basically hanging out and all this particular stuff. So in these particular cases, what you need to understand, you have to kind of perform an exploratory laparotomy directly. Okay, so you have to directly go ahead and do an exploratory laparotomy. So evisceration on the bile staining, you have to go ahead and do an exploratory laparotomy. Now let's talk about the stab injury. Now let's talk about the stab injury to the anterior abdomen. Okay, so what we're going to do, we're going to talk about the stab injury on the anterior abdomen. For this, what I'm going to do, I'm going to draw two kind of patients. So what you need to understand, this is the first patient, okay, and there is a these are the two friends who basically went to the whatever the market to kind of get something or something like that. Okay, they had gone to the market for a number of reasons, right? Now what you need to understand, there was a thief which came in that particular market, and the thief basically stabbed both of these particular patients together. Okay, so thief basically ended up stabbing these particular patients together. Okay, so what you need to understand is that the size of that particular knife was the same, right? So the size of the knife was the same. So this is, let's assume that there is a patient A and this is a patient B. Now please try to understand this point. How will the injury would have happened? So what is, like, whenever, let's assume that there is a patient who has come in front of you and the patient is basically coming with a stab injury to the abdomen. Now what are you kind of concerned about? You are the main trauma surgeon in the the trauma center. What are you concerned about? You're concerned about that whether that knife would have injured some intra-abdominal organ or not. That's what you're concerned about, right? Now for that, if at all the knife has to injure some intra-abdominal organ. It has to kind of pass that particular peritoneum, right? If at all it has not breached the peritoneum, it is not going to kind of go ahead and injure that intra-abdominal organ, right? Are you understanding my point? So your aim as a trauma surgeon is to understand whether that knife was able to cross the peritoneum or not. Because if at all it has not crossed the peritoneum, the patient is safe. You just can take the sutures and you can send the patients home. But if at all it has crossed the peritoneum, now there is a definitive risk that it would have, it could have injured some intra-abdominal organ. Still, we are not sure. Are you understanding my point? So whenever these particular patients come to you in the emergency, what is the next step which you're going to do? You're going to perform local wound exploration, LWE. What does the LWE? Local wound exploration. Now I told you that whatever you do in your life, you have to have some aim. So what is the aim of this particular local wound exploration? To see whether the peritoneum has been breached or not. Now, in this particular patient, what you need to understand, it is going to be negative. It means that the peritoneum has not been breached. On the other hand, over here, it is going to be positive. So if at all the local wound exploration is negative, as was in the patient A, you are very sure, right, that it has not crossed the peritoneum. So definitely intestine, liver, spleen, everything has not got injured. So over here, what you can do is you can just take the stitches and you can send the patient home. Yeah, go home. That's fine. If at all it is kind of positive, it means that the peritoneum has been breached. Are you sure some intra-abdominal organ injury has taken place? No, not really. You're not sure about that. So here what you need to do is you need to admit the patients. You have to get the CT scan done. You have to monitor these particular patients. And if at all these particular patients deteriorate, then you go ahead and perform what you call as an exploratory laparotomy. I hope you are able to understand this particular point. Okay. So yeah, I hope you are able to understand this point. It is not called as a direct wound exploration. It is called as a local wound exploration. I hope you have understood this point. Okay. Reconded. Okay. So yes. So absolute, but you're right. Okay. So stab injury, what you need to understand is if at all there's a stab injury to the anterior abdomen, what you basically do is you perform this local wound exploration. If at all it is positive, you admit the patient, you monitor the patient. If at all the patient deteriorates, then you perform a laparotomy. But if at all the local wound exploration is negative, then you basically discharge the patients. Yes. I hope you have understood. Now quickly revise this particular management protocol for the penetrating abdominal trauma. What is the first thing which we are going to see? Peritonitis. If at all the peritonitis is present, straight away exploratory laparotomy. If at all the peritonitis is not present, then you look for the hemodynamic stability. If at all the patient is hemodynamically unstable, then what you do? Straight away exploratory laparotomy. If at all the patient is hemodynamically stable, there can be two scenarios. There can be a gunshot injury or there can be a stab injury. If at all there is a gunshot injury, what you need to understand, if at all the gunshot injury is to the anterior abdomen, then you have to perform a laparotomy, exploratory laparotomy. But if at all there is a gunshot injury which is to the other parts, let's assume back or the flank or something like that, in that particular scenario you have to perform a contrast and a CT scan, and if at all that is positive, then you go ahead and do an exploratory laparotomy. But let's assume that there is a patient who is hemodynamically stable, that's fine, and there is a stab injury. There's a stab injury. If at all there's a stab injury to the anterior abdomen, then what you do? I messed up. So what you need to understand, if at all there's a stab injury to the back and the flanks, you perform a CT scan, and if at all that is positive, you go ahead and do an exploratory laparotomy. But if at all there's a stab injury, and in the question they're saying that, you know what, there is an evisceration or there is a bile staining of the clot, so there is a omentum which is hanging out. In that particular scenario, no other investigation needed, straight away exploratory laparotomy. But if at all there is a stab injury to the anterior abdomen, what you basically have to perform is a local wound exploration. So local wound exploration, if at all that is positive, then you admit the patients, you monitor the patients. If at all the patients deteriorate, then you go ahead and perform exploratory laparotomy. But if at all the local wound exploration is negative, it means that the peritoneum has not been breached. There is no chance that the intra-abdominal injury would have kind of taken place. So you just take the stitches and you discharge the patient from the trauma center itself. Okay. Now in the splenic injury, I'll just talk one small bit about it. So what you need to understand, what is the most common it is the most common organ which is injured in the blunt abdominal trauma and everything. You all know that. Now coming to the management, because most of the questions which are asked on the splenic injury is based on the management. So what you need to understand over here is that if I tell you that, you know what, there is a patient who is having a blunt abdominal trauma, the contrast and CT scan was done, the CT scan showed a grade 4 splenic injury, and the blood pressure of the patient was 128 by 70, 116 by 72 millimeters of mercury. What is the next step in the management of this particular patient? I would like you to guys to answer. So please answer it in the comment box. What is going to be the management of this particular patient? So I'll repeat my question. Blunt abdominal trauma, splenic injury grade 4 on the CT scan. The blood pressure of the patient is 116 by 72 millimeters of mercury, and heart rate is, let's say, 104 per minute. What is the management of this particular patient? Hypovolumic resuscitation. So okay, you will not perform a exploratory laparotomy or the splenectomy or something, grade 4 injury. Anybody else? You will not perform an exploratory laparotomy or the whatever this. No, okay, you will not. So please try to understand this. The management of a splenic trauma is not based on the grade of the injury. It is based on the hemodynamic stability of the patient. Okay, so here the patient is hemodynamically stable. So yes, you will give the fluids and you will monitor the hematocrit and the abdominal girth and everything. So you'll have to go on the grounds of a conservative management. But if I change that particular question, if I say that, you know what, there is a patient, road traffic accident, CT scan showing a grade 3 splenic injury, and the blood pressure of the patient is, let's say, its systolic blood pressure of the patient is 82 millimeters of mercury. Then you will have to explore and you have to see from where the bleeding is there and all those particular stuff. I hope you have understood this particular point, guys. Okay, understood? So what you need to understand over here is the decision whether you are going to operate on the patients with a splenic trauma or not is based on the hemodynamic stability. It is not based on the grade of the splenic injury. I hope you have understood this particular point, guys. Okay, very, very important. That is what you need to understand over here. Then there's something which is called as an OPSI. So what is this OPSI? It is an overwhelming post-splenectomy infection. It is not an opportunistic post-splenectomy infection. Some students kind of say that. So what you need to understand is that it is overwhelming post-splenectomy infection. Okay, now why does this occur? So what you need to understand is that spleen, basically it's not a vestigial organ. It basically is important. Why it is important? Because it basically helps you fight what you call as an encapsulated organisms like Coccobacillus and the pneumococcus and whatever this H influenza and all this particular stuff. After doing a splenectomy, there is an increased risk of suffering from the infection by all these particular kind of things, and that is the reason why what you need to understand is that you have to kind of immunize the patients before doing a splenectomy against these encapsulated organisms. I have kind of stretched it a bit, but what you need to understand, OPSI is basically an life-threatening kind of condition, and if at all that happens, it has a high mortality, and that is why you have to ensure that you have immunized the patients before the splenectomy. And in case of an emergency splenectomy, you have to immunize the patients before you discharge the patient from the hospital. That is by the post of day 5 or something like that. I hope you're able to understand this point. Encapsulated organisms, high mortality. OPSI is basically what you call as overwhelming post-splenectomy infection. Okay, so I hope you have understood this particular point, guys. Okay, right. Now in the liver trauma, again the same thing. What I want to kind of cover over here is that in the liver, it is all the more important. In the spleen, at least you have an option that you can actually kind of take the spleen and you can throw it off. You can actually do that. In the liver, you cannot do that. So in the liver, it is all the more important that you try to kind of manage these particular patients conservatively. So again, the decision whether you operate on these particular patients or not is not based on the grade of the liver injury. It is basically based on the hemodynamic stability of the patient. Okay, so if at all, let's say the patient is hemodynamically unstable, and let's assume that you become a surgeon. Okay, for the for let's say next few minutes, you become a surgeon. You are the one who is operating. You have opened the abdomen, and now you basically entered in the abdomen. What you find is there's a lot of blood and everything. You basically suck that particular blood out. Then you see that, you know what, the bleeding is coming from the liver. What is the first thing which you're going to do? You're going to kind of push that particular stuff. Okay, so what you're going to do, you're going to kind of, whatever the liver parenchyma is there, you're going to kind of push that. So it's very similar. Let's assume that you are running and you fall down or something like that. If it was the bleeding starts, what is the first thing you're going to do? You're going to apply the pressure over this. Okay, so in the similar manner, what you basically do is in the liver, you kind of push that particular lobes to kind of towards together. Okay, then what you can do is you can take up mops and you can pack that particular kind of a liver all throughout. Okay, so with the intention of creating a tamponade. So over here also you kind of tie all those particular bandages and the shirts and everything, right? So why? Because you want to create a tamponade. So push. Okay, right? You understand my point? So you basically are able to kind of create that particular tamponade. If at all the bleeding stops, if at all the bleeding stops, then you shift the patients to the ICU. And then you perform what you call as a damage control surgery. Okay, so if at all the bleeding has stopped, what you basically do is you kind of what you call as you shift the patient to the ICU and you basically go on the kind of grounds of your damage control surgery. If at all the bleeding continues, then what you do, you perform a Pringles maneuver. What on earth is this particular Pringles maneuver? Pringles maneuver is when you basically compress the hepaticoduodenal ligament. Okay, hepaticoduodenal ligament. What is this hepaticoduodenal ligament? It is a ligament which is basically coming from the liver to the duodenum. Okay, so what is basically the content of this hepaticoduodenal ligament? It is the portal triad, which is basically your hepatic artery and whatever the bile duct and the portal vein. Okay, so when you compress this particular hepaticoduodenal ligament, which is basically once you compress this, and if at all the bleeding stops, it basically means that the source of the bleeding was either the hepatic artery or the portal vein. You understand my point? But if at all the bleeding continues, it means that the bleeding was basically from the hepatic vein, because in the liver there are three sources of the blood. One is the hepatic artery, second is the portal vein, then there is a hepatic vein. So I hope these are all important things, guys. Okay, so what is the Pringles manure? You compress the hepaticoduodenal ligament. What are the contents of the hepaticoduodenal ligament? Portal triad. So bile duct, that's fine, but we have a hepatic artery and we have a portal vein. Okay, now once you compress this, if at all the bleeding stops, what you basically need to understand is that the source of the bleeding was either the hepatic artery or the portal vein. But if at all the bleeding does not stop, then the source of the bleeding was a hepatic vein. Okay, now lastly, there is something which is called as a so here it is not kind of written. So what you need to understand is that the management of the liver trauma can be summarized by 4 P's. So what are these particular 4 P's, guys? First P was push, that you push the particular lobes together. What is the second P? Second P is pack. You put what with the mops and everything, you pack that particular liver. Third is basically Pringles. You kind of compress the hepatic ligament. And the fourth P is plug. So you basically put in balloon over there. So there's a like, forget about it. But the fourth thing is plug. So what you basically do is with the help of a balloon, you try to create a tamponade over that or something. That is basically one of the last resorts. Okay. After that, you'll have to kind of form the resection. So the 4 P's of the liver trauma, this is important. What you need to understand is push, pack, Pringles and plug. These are the 4 P's of the liver trauma, and this is what I've just kind of talked to you about. The Pringles manure, it's very, very important. What is the Pringles manure? You compress the hepaticoduodenal ligament. If at all the bleeding stops, it means that the source of the bleeding was either the portal vein or the hepatic artery. But if at all the bleeding continues, the source of the bleeding was either the hepatic vein or the inferior vena cava. I hope you have understood this particular point, right? Now, let's talk about this particular damage control surgery. What is this particular damage control surgery? In the damage control surgery, what you basically do is that whenever you have a patient with a polytrauma, what you basically do is you there are the 3 phases of the damage control surgery. In the first phase, what you do, whatever might kill the patient, you basically take care of that. For example, let's say if at all there is a bleeding which is happening from some major source or something like that, you control that particular bleeding. Let's assume that there is a contamination which is happening. Let's say the bowel has perforated or something like that. Are you going to kind of do the resection, anastomosis and the repair and everything? No, not really. What you're going to do is you're going to put like the proximal part of the bowel, you're going to kind of bring it out. Are you understand my point? So what you basically do is an emergency intervention. What do you understand by an emergency intervention? Whatever is needed in order to what you call as a sustain the life of that particular patient. Are you understand my point? Whatever is kind of needed in order to kind of keep the patient alive. Okay, that's what you're going to do in the phase 1, like in the phase 1, right? In the second phase, what you basically do is you shift the patient to the ICU and then you take care of this particular deadly triad. So what we have found was that in the patients of a polytrauma, even if the surgeon does a very, very fantastic surgery, you know, like all these particular interventions done at the same time and everything, still the patients were dying. And why were these particular patients dying? Because of this particular lethal triad. What is this particular lethal triad? Hypothermia, metabolic acidosis and the hypercoagulable state. So what you need to understand is that already the patient is not in the good physiological state because a lot of blood has kind of lost and all those particular things. So patient already suffered from a polytrauma. So the physiological status of the patient is not kind of at the normal level. And then you basically do a surgery for let's say 8-10 failures or something like that. So surgery per se is also like a trauma to the patient itself, right? So we have an entire chapter on the metabolic response to the surgery. So you understand my point? Surgery per se is a trauma to the patient. So already the patient's physiological state is not normal, and then you do a prolonged surgery which is going to further harm the patient because of these 3 factors: hypothermia, hypercoagulable state and the metabolic acidosis. So over a period of time we had some kind of brains, and then we thought that, you know what, let's do what is needed to save this particular patient at this point of time. Then you shift the patient to the ICU, you resuscitate the patients, you take care of this particular deadly lethal triad, and once that is taken care of, you can bring the patient back to the operation theater and then you can perform a definitive surgery. So these are the 3 phases of the damage control surgery. The 3 phases of the damage control surgery are these 3. Then there is stages of the damage control surgery. What are the stages of the damage control surgery? There are the 5 stages of the damage control surgery. What is the stage 1? Patient selection. So every time the patient is coming to you with the trauma, you're not going to kind of perform a damage control surgery, right? So you have to select in which patients you have to perform a damage control surgery, in which patients you have to perform an ETC, that is like early total care. Okay, so I understand my point. So that is what you need to understand. You basically need to bifurcate these particular patients. Patient selection is the stage 1. Stage 2 is the same like that, emergency intervention in the surgery. Then Stage 3 is the phase 2. That is what you basically do in the ICU. That is the resuscitation and everything. Stage 4 is basically definitive surgery. And the stage 5 is abdominal closure. So after this particular surgery and everything, after even the stage, are you understanding? So final stage is the abdominal closure. That has a separate stage for that. Okay. So this is about the damage control surgery. This is again a very, very important topic for you guys. Okay. Right, now this is all I had to kind of cover in the abdominal trauma and everything. Just give me a minute, I'll take a couple of questions. First evaluate, second ICU. Yeah, absolutely right. So first is not evaluate, first is emergency intervention, Satyaja. Please remember this. Okay, so let's assume that there's a bleeding or the contamination or something like that. You take care of that. Second is ICU, where you do the resuscitation. Third is the definitive surgery. Even in the first stage, there is a laparotomy which is done. But see, let's assume that if you want to do a laparotomy, there are a couple of things which you can do. For example, the perfect example is this. Okay, so over here, what did I tell you? That you pack with the mops and everything. And if at all the bleeding stops, then you shift the patients to the ICU. Like, does it mean that the management of the liver trauma is done? No, not really. It just means that the present emergency scenario has been kind of taken care of. The emergency which we had was that there was a continuous bleeding which was happening from the liver. Otherwise, the patient would have exsanguinated, right? But over here, once the bleeding has stopped, now you shift the patient to the ICU. Whatever the emergency thing was there has been taken care of. You resuscitate the patients, and once the patient is stable, you will go back again and you will do a definitive repair. Okay, I hope you are able to understand this particular podcast. Okay, got it? So this is all about the abdominal trauma, guys, which I wish to kind of communicate with you guys. Guys, this is the QR code which we have, okay, for the surgery unplugged for the WhatsApp. This particular QR code is not working. If somebody was trying to tell me, okay, don't worry, even if it's not working, it's okay. My number has also been kind of given in the description box if you kind of wish to kind of communicate with me. But I have checked. I think this particular QR code is working. But if not, it's okay. The link of the WhatsApp group as well as the number has been given in the as a description box. If you want, you can kind of check that up. This is again the YouTube channel. If you wish, you can kind of follow me on this, and this is the Instagram. If you want, you can just follow me. This is not yet active, I understand that, but it's going to be active pretty soon. Okay, so yes guys, that's all I wish to kind of cover with you guys today. We have covered this was a one shot revision part 2. Part 3 I will do tomorrow. Okay, and I will do tomorrow. I'm really sorry, yesterday I was not able to do because of some family commitments. I was not able to kind of come live, but don't worry, I understand that your exams are very near, and I will try my level best that tomorrow we do 3, and if needed, day after tomorrow we'll do 4 as well. Okay, but tomorrow definitely we'll meet and we'll try to kind of cover many things. Okay, right, thank you guys, thank you so much. I hope you like this particular stuff. If you like it, please help me by kind of sharing with few people or something like that. Let's say your juniors or something. That will help me a bit, and in order to reach more people. See, I was always sick. I have been a teacher for like 4-5 years or something. In between, when I was doing my urology, I was very inactive because obviously it was a full-time residency kind of a thing, and I like teaching, and I would like to kind of reach more people or something like that. So if you want, you can please kind of, if you wish, if you like this particular session, please consider sharing with other people. So urethral trauma, I'll definitely cover that. Okay, so I'll definitely cover that. Don't worry, in the urology section, I'll definitely cover that. So entire urological trauma, I'll try to cover that. Okay. Right. Okay. Chalo. Good night. Thank you so much. Happy studying. See you tomorrow. Don't take tension. Just relax. Calm down. You'll do decent. I won't say you'll do awesome. I understand. Every student is different, but I understand. Whatever you have read, just kind of focus on delivering on that on the day of the exam. We'll talk about the exam on the last day as well, but don't worry. But yeah, that's all. Let's not waste any further time. Go back. Study well. Read. See you tomorrow. Bye-bye. Good night. See you.